Okay, good morning. Today is January 28th. I'll call to order the Green Mountain Care Board's hearing. Today we have a very important and lengthy presentation relating to reference-based pricing. We'll be discussing Medicare benchmarks, evidence and policy design relating to the Green Mountain Care Board's work to implement a reference-based pricing system. This work has been led by Elena Barabee here at the board, with the assistance of a number of outside experts in this area. And thanks to Elena and Kirk Williamson for preparing today's series, which will help set the stage for how Medicare payment works and some information about how we're going to use evidence-based regulations to right-size prices and hospital budgets. With that, I'll turn it to Ms. Barabee to provide some introductory remarks and introduce our speakers today.
Great, thank you so much. So we have a lot of content, so I'll try to keep it brief. Michelle, if you want to go to the next slide. All right, so just quickly on background, as many of you know, one of our state has some of the highest hospital prices, and this is not unique to Vermont. Many other states are grappling with high prices across the country. We performed an analysis last year looking at just the state employees and teachers and estimated approximate savings of $400 million over a period of time associated with establishing hospital price caps or a reference-based price. And this led to kind of subsequent work in this area and now a scaled approach to thinking about hospital prices. Next slide, please. So Act 68 just last year directed the board to establish reference-based prices for hospitals no later than fiscal year 27, to review and monitor reference-based prices annually as part of our hospital budget review process, and then to identify conditions for modification or termination of reference-based prices if something's not working or we need to adjust our approach. And then consideration for expanding prices and rate setting to non-hospital services such as primary care, perhaps setting floors or other kind of standardized approaches. So you can go to the next slide. Given this tight timeline and kind of the immediate need to start dealing with prices, we proposed a phased approach. We started discussing this phased approach last summer, given many of the operational considerations that would be required to establish a rule. We not only have to go through the rulemaking process, which can take upwards of 6 months, but also to go through the state's procurement process is quite lengthy when getting contract support to do some of the analytic modeling. So with that, we're trying to figure out what we can do within the context of our hospital budget process. Our finance team has met with hospitals about an approach to kind of start that work, and we'll bring guidance before you here soon and kick that off really to issue guidance in March. There, we'll start looking at differential hospital price growth and starting to prepare the delivery system for anticipating price caps. The phase 2, which we're talking about today, Michelle, is really a longer time horizon, but we really need to, we've been starting this work and learning as much as we can so we can hit the ground running. We have a report due back to the legislature next month on where we are with this work and some policy options. We've met with other states and experts in the field to learn about different ways of setting up reference-based prices and how we might adapt it for Vermont's local needs. Go to the next slide. So key challenges and considerations as we move forward, really thinking about balancing cost containment with hospital financial viability. We know this is an ongoing issue, and hence the need for transformation led by our partners at the Agency of Human Services, particularly in those areas where we have low volume hospitals and we're managing potential impact on commercial insurance rates and insurer solvency. So we really need to think about these things in tandem and perhaps adopting a more unique approach, not a one-size-fits-all as we move forward. We need to ensure that commercial rate adjustments adequately reflect the structural differences across hospital costs. So not every hospital, again, is the same and may warrant a different approach. As part of this system, we also have to kind of monitor what's happening to quality and access and make sure that we put our money kind of where we want to see certain services and make sure that it kind of all adds up in the end. Coordinating reference-based prices is, with other kind of payment reform initiatives such as hospital global budgets and the AHEAD model is very important. I believe the legislature saw reference-based pricing as a step towards establishing more efficient hospital global budgets, which could provide hospitals with more predictable revenue over the long run. So that is the kind of primary goal here as we move forward. Michelle, thank you. So today, what we'd like to focus on, we kind of brought together some experts in the field that can help us really round out our understanding and provide a baseline for this work moving forward. We hope to build a shared understanding of Medicare payment systems and kind of the rationale for a Medicare reference for these hospital price caps. We'd like to increase awareness of Vermont's Medicare payment landscape and all the different ways and the complexities of and current methods employed to establish Medicare payment. And then we'd like to leverage lessons learned from other states. Other states have dabbled in reference-based pricing in a variety of contexts. So looking at what we can learn and kind of move ahead with and learn from others' experiences is very important. And then certainly, we want to support Green Mountain Care Board stakeholder engagement. So this is an opportunity for public comment and to solicit feedback from a variety of individuals and folks in the field. And then we'll continue that engagement work as we move forward. So with that, we can go to the next slide. Just a quick view of what we have today. So first we'll start with Medicare payment methods. We'll have a 101. We'll review Vermont's Medicare payment landscape. So what does it mean in Vermont for specific hospitals? Then we'll learn about other states' experiences with reference-based pricing. We'll break for lunch and conclude with evidence-based regulation. And then we'll have a discussion and public comment. So it's a lot to absorb, and we hope you'll stick with us, but I will not wait much longer and pass it over to our first speakers, Christine Monahan and Ariel Winter. Thank you so much.
Good morning. Thank you so much for inviting us to speak. I just want to make sure that you can see my slides. Okay, great. My name is Ariel Winter. I'm a consultant to Georgetown Center on Health Insurance Reforms. I used to work at CMS and the Medicare Payment Advisory Commission. With me is Christine Monahan, who will say hello.
Hi, Christine Monahan. I'm an assistant research professor at the Center on Health Insurance Reforms. I do a lot of work on commercial health insurance market, but I've been expanding my understanding of Medicare payment over the past couple of years in recognition that state and federal policymakers are looking at it as a model or benchmark for commercial reforms.
All right. As Elena said, we'll be giving you an overview of traditional Medicare payment systems for hospitals and physicians because you're considering using Medicare as the benchmark for reference-based pricing for hospitals. Traditional Medicare is sometimes called fee-for-service Medicare, and it's distinct from Medicare Advantage, which is the managed care part of the program. This slide highlights key features of each of the 4 Medicare payment systems that we'll be discussing today. The first row describes the Inpatient Prospective Payment System, or IPPS, which pays for inpatient care. Under the IPPS, Medicare pays for an inpatient stay using prospective payment, which means that the hospital receives a fixed payment for the entire stay. The IPPS uses relative weights to adjust the payment rate based on the patient's condition and relative costliness. The relative weights are called Medicare Severity Diagnosis Related Groups, or MSDRGs. The IPPS payment rates are updated annually based on the Hospital Market Basket Index minus a productivity adjustment. CMS also makes other adjustments to IPPS payments, such as extra payments for high-cost outliers and indirect medical education. Christine will discuss these adjustments in more detail in a few minutes. The next row shows the Outpatient Prospective Payment System, or OPPS. Under the OPPS, Medicare pays for a hospital outpatient service, also using prospective payment. The unit of payment in the OPPS is an ambulatory payment classification group, or APC. And that's a set of HCPCS codes that are grouped together based on clinical and cost similarity. CMS assigns a relative weight to each APC, which is used to determine the payment amount. OPPS payment rates are also updated annually based on the Hospital Market Basket Index minus a productivity adjustment. CMS also makes other adjustments to OPPS payments, such as additional payments for certain rural and cancer hospitals. The next row shows the physician fee schedule, which covers services provided by physicians, nurse practitioners, physician assistants, and other health professionals. The fee schedule uses a form of prospective payment. The unit of payment is an individual HCPCS code. The relative weights are called relative value units, or RVUs. The update is set by law, and it varies depending on whether the clinician participates in an advanced alternative payment model, such as an ACO. And I'll discuss this more later on. CMS makes other payment adjustments, for example, based on the type of provider and quality of care. Before I move on, it's important to point out that when a service is provided in a hospital or other facility, Medicare usually makes two separate payments, one to the hospital and one to the physician. Now I'm on to the last row, critical access hospitals. These hospitals receive payments for inpatient days, swing bed days, and outpatient services. They can also choose to be paid for professional services. Unlike other payment systems that are based on prospective payment, critical access hospitals are paid based on the actual costs they incur to treat patients. CMS pays them interim per diem amounts during the year and settles up at the end of the year. The cost data come from hospital cost reports submitted to CMS. There's an important policy called sequestration that applies to all Medicare payment systems. Under sequestration, all Medicare payments are reduced by 2%. Next, we'll explain how each of these payment systems works in more detail, and Christine will be starting with the IPPS.
Thanks, Ariel. The Inpatient Prospective Payment System, or IPPS, is what Medicare uses to pay most general acute care hospitals, and is typically what is used when people talk about benchmarking hospital prices to Medicare. Nationally, IPPS is the most common payment system for hospitals, although Vermont is an anomaly, as fewer than half of your hospitals are paid under IPPS. I'll walk you through the steps CMS takes to calculate a hospital's adjusted base rate, which takes into account geographic and case-specific factors. I'll then discuss different adjustments that can apply on top of that adjusted base rate to account for facility-specific characteristics and certain unique circumstances that may apply to a particular patient stay. Next slide. I think a common misperception among those of us focused on the commercial market is that Medicare has a long, cumbersome fee schedule with specific rates for different services. In actuality, for IPPS hospitals, Medicare begins with a single operating base rate, which is intended to compensate hospitals for labor and supplies, and a single capital base rate, which covers property-related expenditures. This year, the operating base rate is more than $6,700, while the capital base rate is just over $500. The first adjustment to this base rate is the application of the hospital's wage index. Even though healthcare professionals are paid under a separate system than hospitals, hospital labor costs make up a significant portion of their operational expenses. This includes much of the nursing staff, technicians, billing agents, and other administrative and operational staff. Costs for hospital labor can vary significantly due to local conditions. To account for this, CMS applies a wage index reflecting average hospital hourly labor costs to the IPPS base rates. Every metropolitan statistical area, or MSA, in the country has its own hospital area wage index. For the rural parts of each state that are not within an MSA, CMS calculates a single statewide rural area wage index. That statewide rural area wage index cannot be higher than any MSA within the state. A hospital's wage index will be either above or below 1, depending on whether the area's average hourly wage is above or below the national average. This year, the lowest wage index is just shy of 0.25, while the highest is about 1.8. Vermont's hospitals appear to all be a little bit below 1, either 0.9516 or 0.9650, depending on the hospital. In calculating a hospital's adjusted base rate, CMS will multiply a portion, about 2/3 of the operating base rate, by the hospital's wage index, while holding the remainder of the base rate flat. This approach accounts for the fact that some, but not all, of a hospital's operating costs are related to labor. So, if a hospital's wage index is below 1, it will see a portion of that operating base rate reduced, since it's assumed to have lower than average labor costs. If its wage index is above 1, it will see a slightly bigger portion of the operating base rate increase, since it is assumed to have higher than average labor costs. The wage index also applies to capital payments, although that formula is a little bit different. The index applies to the full capital rate, but the magnitude of change is smaller on both sides. Importantly, CMS allows hospitals to reclassify from one area to another to get a higher wage index if certain circumstances are met. So a hospital could be in a statewide rural area and move to an urban area wage index, or from one urban area wage index into another higher one. Some hospitals maximize their Medicare payments by requesting that CMS treat them as rural hospitals to qualify for certain bonus payments and privileges, while keeping an urban area wage index to get higher base payments. Next slide. The second adjustment brings in the specific circumstances of the patient's stay, referred to as the case mix. CMS evaluates each inpatient stay on a variety of factors, including their principal diagnosis and any secondary conditions that can arise as comorbidities or complications, as well as the provided procedure and the patient's age, sex, and discharge status. The specific combination of factors will correspond to a Medicare Severity Diagnosis Related Group, or MSDRG, as Ariel mentioned. There are 772 MSDRGs in 2026. Each one has a weight that is tied to the expected costliness or relative resource intensity of that patient's stay, with the average set at 1. A relatively simple procedure on a healthy, relatively young beneficiary could have a weight as low as 0.17, while the weight of some complex procedures on an older, unhealthy beneficiary could exceed 30. To get to the hospital's adjusted base rate, CMS will multiply a hospital's geographic adjusted base rate by the weight of the applicable MSDRG for that case. As the Brown team, I believe, will talk about more this morning, one approach to setting prices off of Medicare rates would stop here and just use these hospital adjusted base rates, in which you've taken the hospital's labor costs and circumstances of the specific patient stay into account. There'll be some variation between payment levels based on the wage index, but payments will look pretty similar, especially in a state like Vermont. As far as Medicare goes, however, there are a lot more adjustments and add-ons that come into play. And so another approach is to consider some or all of these. As I mentioned before, these adjustments are intended to account for variations across facilities and unique circumstances that some patient stays may bring. Next slide. One type of adjustment is for rural or isolated hospitals. I won't get into the eligibility rule for each of these, but I do want to highlight how different classifications can affect payment under IPPS. Sole community hospitals, of which Vermont has multiple, can elect to use a hospital-specific base rate that takes into account their past costs rather than national average costs. Medicare-dependent hospitals get the IPPS hospital adjusted base rate, but then they get to add on 3/4 of the difference between what they would have earned under hospital-specific cost base rate and their IPPS base rate. I believe Vermont had one Medicare-dependent hospital in 2023. I'm not sure if it still uses that designation. Low-volume hospitals receive a bonus payment of up to 25% the payment rate per discharge. The amount of the bonus is set on a sliding scale tied to the hospital's annual volume. Sole community hospitals and Medicare-dependent hospitals can also qualify as low-volume hospitals, so they can get these bonuses can be additive. And I know that several Vermont hospitals qualified for the low-volume adjustment as of 2023. Vermont also has a few rural referral centers. This is another status that can overlap with some of the other designations I've mentioned. Rural referral status does not confer any extra payment under IPPS, but it does give hospitals an easier pathway for reclassifying to a higher wage index area, which, as I discussed before, translates into a higher hospital adjusted base rate. Next slide. Hospitals also can receive more money if they serve a high share of low-income Medicare and Medicaid patients. We describe the eligibility rules for these disproportionate share hospitals, or DSH hospitals, on the slide. Again, I'll focus on how they can affect payment. I think all of your IPPS hospitals qualified for DSH, at least as of 2023. And so there are 3 types of Medicare payments that DSH hospitals may be able to receive. First, they can receive a percentage increase on their IPPS operating payment rate. Excuse me. Second, they can receive an additional uncompensated care payment that is based on the amount of uncompensated care they provide relative to all DSH hospitals. While individual hospital circumstances may vary, in the aggregate, Medicare is paying out significantly more in uncompensated care payments than DSH operating payment adjustments. Finally, and I'm not sure this applies to any Vermont hospitals, but certain large urban hospitals can receive capital DSH payments as a percentage of their IPPS capital payment rate. This is generally a small payment, both as far as the individual hospital goes and in some for Medicare. Next slide. The IPPS system also provides higher operating and capital payments to teaching hospitals to cover the indirect costs of training medical residents. This accounts for things like the fact that it'll take residents in training longer to perform the same procedure as attending physicians. The amount of these indirect medical education payments vary by a teaching hospital's intensity, which is a measure of the number of residents relative to inpatient beds for the operating payments, or the number of residents relative to the average daily inpatient census for capital payments. CMS will also reimburse teaching hospitals for direct expenses of residency, but this is separate from the IPPS payment and not included there. Next slide. I won't go into the details on the other adjustments and add-on payments that Medicare can make under IPPS, but you can see several on the slides here. Some of these, like quality performance and bad debt, will vary facility to facility. Others are specific to an individual inpatient stay, whether it's paying a bit less because the patient transferred out, or more for a new technology or an extraordinarily costly stays. With that, I'll hand things back to Ariel to talk through the other 2 prospective payment systems on our agenda.
Thank you. This is an overview of how CMS sets rates under the OPPS. We'll cover each of these steps in more detail on the next slide. In step 1, CMS starts with a conversion factor, or base rate, which is about $91 in 2026. In step 2, CMS adjusts the base rate for geographic differences in labor costs. To do this, they apply the hospital wage index to 60% of the base rate, which is the share of hospital outpatient costs related to labor. In step 3, CMS adjusts the payment for the complexity of the service. CMS assigns about 8,000 HCPCS codes to more than 800 APCs based on the clinical and cost similarity of the codes. Each APC has a relative weight, which reflects the relative resources used for the services in that APC. And the relative weight is based on the mean cost of the services in each APC. Have the slides disappeared from the screen? Are you still seeing them? Okay,
they disappeared.
Try sharing again.
That's better.
Okay. Sorry. Let me try this again. Okay. Can you see them now? Okay. The relative weight is based on the mean cost of the services in each APC. CMS may also make other adjustments to the OPPS payment rates. Here are some key ones that are relevant to Vermont. There's a 7.1% add-on to payments for rural sole community hospitals. CMS also applies site-neutral policies. Payment rates for certain services provided in off-campus outpatient departments are set equal to rates paid under the physician fee schedule. In addition, CMS makes outlier payments if the cost of the service is much higher than the payment rate for that service. Now we'll move on to the physician fee schedule. This is an overview of how CMS sets rates under the fee schedule. First, CMS starts with a conversion factor or base rate, which is either $33.40 or $33.57 in 2026. I'll explain why there are two different conversion factors in a few minutes. Second, CMS adjusts the conversion factor for the costliness of the service. And third, CMS adjusts the payment rate for geographic differences in input costs. The second and third steps are different than the methods used for the IPPS and OPPS. This is because CMS does not collect cost data from clinicians, and instead they use estimates of relative resource use, called relative value units or RVUs. And there are three types of RVUs. Physician work, which is intended to reflect the time, effort, skill, and stress associated with each service. Practice expense, which accounts for the cost of office rent, supplies, equipment, and staff. And professional liability insurance. I want to note that the practice expense RVUs for services provided in a facility like a hospital are typically lower than the practice expense RVUs for services provided in a clinician's office. This is because CMS makes a separate facility payment that covers the facility's labor and overhead costs. For example, if a patient has a clinic visit in a hospital outpatient department, Medicare pays the physician for the visit under the fee schedule and also makes a separate payment to the hospital under the outpatient PPS. Each of the three RVUs has its own geographic adjustment factor because each type of RVU has different inputs. CMS also makes other adjustments to fee schedule payment rates, and here are a few key ones. Payment rates are reduced for certain non-physician practitioners. For example, rates for nurse practitioners and physician assistants are 15% lower than the rates for physicians. In addition, CMS pays a 10% bonus for services provided in a health professional shortage area, and that's designed to attract clinicians to these areas. There are also adjustments for quality of care. In 2026, clinicians who participate in an advanced alternative payment model, such as an accountable care organization, receive a 1.88% bonus. They also receive a higher update in 2026 than other clinicians, 3.8% versus 3.3%. And that's why there are two different conversion factors on slide 18. Clinicians who do not participate in an advanced alternative payment model may be subject to payment adjustments based on their performance under something called the merit-based incentive payment system. These adjustments range from -9% to +2%. Performance under the system is measured in four areas: quality, cost, promoting interoperability, and clinical improvement activities. Next, I'll return to Christine, who will discuss critical access hospitals.
So this part will switch gears completely because this type of payment for critical access hospitals is different than anything like we've been speaking about before. And so how Medicare pays for inpatient care as well as outpatient care is different here. Rather than using a prospective payment system where Medicare prospectively determines what is a reasonable payment rate for a given inpatient stay or outpatient service, Medicare pays critical access hospitals, or CAHs, using cost-based reimbursement. Medicare pays the costs the hospital incurred. Medicare moved away from this type of reimbursement model for most hospitals out of concern that it encourages them to keep increasing their costs regardless of value or quality of care. But it can be an important lifeline for certain hospitals that may have uniquely high costs or really variable patient volumes where you can't rely on a steady stream of fee-for-service patients to keep the lights on. So for CAHs specifically, Medicare pays 101% of allowable costs for inpatient, swing bed, and outpatient services, as well as certain ambulance services and for the costs of training medical residents, although most CAHs don't actually take up that last option. And while I won't spend time on this today, as it only applies to a couple of your hospitals in Vermont, I just want to put on the radar that Medicare does reimburse CAHs under a couple other specialized fee schedules if they have distinct psychiatric or rehabilitative units for those beds. Next slide. So focusing on core services, let's begin with Medicare reimbursement for inpatient and swing bed care. Swing beds, if you are not familiar, are beds that can be used either for acute inpatient care or post-acute skilled nursing care, so that patient can stay in the same location and avoid getting transferred to a new setting. Swing beds also provide a steadier source of revenue for the hospital by helping keeping more beds full. It's a particularly attractive option for cause where patient volume is more variable, and because Medicare pays the cause on a cost basis for swing bed skilled nursing care, rather than the skilled nursing facility prospective payment rate, which swing beds at IPPS hospitals get. Now, it's one thing to say that Medicare pays a hospital based on costs, but what does that actually mean? For cause for both inpatient and swing beds, CMS will calculate Medicare's share of allowable costs over the course of a year based on data from the hospital's Medicare cost report, specifically the total average cost per day and total number of Medicare inpatient days. It will then multiply Medicare's share of allowable costs by 101%. From that, it will subtract the total amount Medicare requires beneficiaries to pay for their care, which for inpatient services takes the form of a deductible. Instead of just making one lump sum payment at the end of the year, however, CMS will make interim payments to cause on a per diem amount. These are calculated one or more times during the year based on expected costs and patient days. Depending on the cause cash flow preferences, it may want a higher or lower interim payment. At the end of the cost report year for that hospital, CMS will determine whether the interim payments underpaid or overpaid the CA and either make or collect a settlement payment accordingly. Next slide. CMS handles payment to cause on the outpatient side pretty similarly to inpatient care, although the inputs are slightly different for calculating the Medicare share of allowable costs. Specifically here, it's my understanding that Medicare applies the cause cost to charge ratio to its Medicare charges to get at that Medicare share of outpatient costs. So the primary distinction here is that payments are calculated using a percentage of service charges rather than on a per diem basis. Where this really ends up mattering, and the most important thing to understand, is how beneficiary cost-sharing obligations are calculated on the outpatient side and how this affects payment. Next slide. For outpatient services, Medicare requires that beneficiaries pay 20% of outpatient charges, not costs. And specifically for cause, there's no cap on beneficiary cost-sharing for outpatient services. Hospital charges can significantly exceed their costs and are highly variable across hospitals. The hospitals have full discretion over where to set them. This means, all else equal, a CA that charges higher rates is going to get a lower payment from Medicare for outpatient services than a CA with lower rates. So Medicare assumes that CA is collecting that difference from the beneficiary or the beneficiary's supplemental insurance. I'll walk through one example on the slide. So say the CA charges $2,400 for a service that costs them $600. The beneficiary is going to owe $480, while the Medicare program will only pay about $125. If cost sharing were pegged to costs rather than charges, that beneficiary coinsurance obligation would drop to $120, and Medicare instead would be paying a little more than $480. In the aggregate, MedPAC has estimated that beneficiaries are responsible for more than half of CA outpatient payments, rather than the approximately 20% that beneficiaries pay in the aggregate for OPPS hospitals. Next slide. One final quirk about CAS. As far as professional services go, the default is that healthcare professionals separately bill for their services from the facility under the physician fee schedule, which Ariel explained. But there is an option that CAS can elect whereby the physicians and other non-physician practitioners providing services there can reassign their billing rights to the CA, and the CA can bill for payment at 115% of the physician fee schedule for their care. My understanding is that CAS simply need to alert their Medicare administrative contractor, the MAC, that they've chosen to switch to this method, and then it is in effect until they want to make a change. I'm unaware of any public data identifying which CAS have made this election, but we've heard informally that it's likely the majority of them. And with that, I'll turn it back to Ariel to bring us home.
This table shows the payment update schedule for the Medicare payment systems that we talked about today. We've included this because the timing of updates is important if you're going to use Medicare prices as the benchmark for commercial prices. The first column shows how frequently CMS updates these payment systems. The first three systems are updated annually, whereas critical access hospital payments are updated after hospitals file their interim or final cost reports. The next two columns show the payment cycle and the timeline for when CMS makes changes to the payment systems. CMS updates the IPPS every fiscal year, beginning on October 1st, and they typically finalize these changes in August. By contrast, CMS updates the OPPS and the physician fee schedule every calendar year, and usually finalizes these changes in November. CAH payments change after hospitals file their cost reports. I'm going to switch gears here and talk about the Medicare Payment Advisory Commission, or MedPAC. MedPAC is an independent congressional agency that advises Congress and CMS on Medicare issues. Each year, MedPAC recommends how much payments should change for many payment systems, including the IPPS, OPPS, and physician fee schedule. They assess the adequacy of traditional Medicare payments and recommend payment updates for providers in several sectors. To assess payment adequacy, they evaluate beneficiaries' access to care, the quality of care, providers' access to capital, and how Medicare payments compare with providers' costs. And this process informs their annual update recommendations. MedPAC votes on its recommendations every year in January, and they are published in its March report to Congress. MedPAC does not recommend updates for CAHs because there is no single update that applies to all of these hospitals. MedPAC's goal for the payment updates is to support access to high-quality care from efficient providers, meaning those that have lower costs and higher quality, while encouraging all providers to control their costs and improve quality. Congress is not required to adopt MedPAC's update recommendations and frequently does not. But the Commission's work is important because it gives policymakers objective information about how well Medicare's payment systems are working. To illustrate how MedPAC's process works, this slide walks through their update recommendation for the IPPS and OPPS for 2026. The recommendation was to update the base rates by the current law update plus 1%. This was based on their assessment of payment adequacy for hospitals. They found that beneficiary access to care was positive in 2023, the most recent year for which they had data. They also found that quality of care was mixed, and hospitals' access to capital was positive. In addition, hospitals' aggregate fee-for-service Medicare margin was negative in 2023 at minus 12.6%. It was also slightly negative for a group of relatively efficient hospitals at minus 1%. MedPAC also made a related recommendation to provide additional funds to safety net hospitals. Specifically, they recommended that Congress redistribute disproportionate share and uncompensated care payments through a mechanism called the Medicare Safety Net Index, or MSNI, and add $4 billion to the MSNI pool of dollars. MedPAC had previously recommended that Medicare use the MSNI instead of the current mechanisms to provide additional funds to safety net hospitals. The MSNI is based on the share of a hospital's Medicare patients who are low income and the hospital's uncompensated care costs as a share of total revenue. Congress has not adopted either of these recommendations. Here are some key sources for more information about these payment systems, including a guide to hospital financing and operations that we published in November. This concludes our presentation. We'd be happy to take any questions.
Thank you both very much. Ms. Barabee, anything from you or Kirk?
I just have one question. Could you say a little bit more about how CMS thinks about allowable costs versus those that they don't allow?
Christine, do you want to take this or do you want to give it a shot?
I mean, my understanding, and Ariel, you can kind of expand on this, but these are kind of the costs that are necessary and reasonable for that, and that directly relate to providing patient care, and not kind of other kind of excessive things, if there were TV charges or kind of other kind of like additional costs that might apply or that just are not at all related to patient care, lobbying costs or kind of entertainment charges that a hospital might incur. Those aren't going to be passed along. It needs to be tied to, what you're actually providing to the patient and what we would expect a, reasonable care to include that to encompass.
Yeah, that's right. I have nothing to add to that.
Great, thank you. That's all I had, Chair Foster.
Great, thank you. And I'll open it to the board members.
I can jump in first, if that's all right. I just have a few questions. Thank you so much for the presentation. It was very thorough and organized and helpful and clear, so I really appreciate it. A few questions, they're just a few from the presentation. For OPPS, the cancer hospital designation, is this for specific cancer hospitals like Sloan Kettering and Dana-Farber, Fred Hutch, or are there other hospitals like general hospitals, academic medical centers that can qualify for the cancer hospital designation?
Christine, you want to take this or do you want me to give it a shot?
Yeah, this is just for the 11 PPS exempt cancer hospitals.
Okay.
And so it is none of which are in Vermont. And so, yeah, that is all that it applies to.
Yeah, that's designated in statute.
And then with regards to the disproportionate share payments under the IPPS system, it's related to uncompensated care. Is the expense, how is the expense associated with uncompensated care determined? Is it off of charges or is it off of expected Medicare payments?
So the uncompensated care costs are reported, each hospital reports its uncompensated care costs in its annual hospital cost report. And what CMS does is they tally up all of the total uncompensated care costs across all IPPS hospitals that are eligible for DSH payments, right? And then they determine for each hospital what share of total uncompensated care costs are accounted for that specific hospital. They have a pool of dollars, right?
Yep.
And they allocate those dollars to specific hospitals based on each hospital's share of total uncompensated care costs across all IPPS hospitals. But it's important to point out that only DSH hospitals are eligible to receive any uncompensated care payments. Christine, you want to add anything to that?
Yeah, no, and I think just when they're kind of calculating uncompensated care, they're looking at the hospital cost report and it's kind of charity care, financial assistance, and kind of certain bad debt that Medicare is not reimbursing is kind of what gets factored into that. And so, yeah, there are like very specific rules on what the hospital can and cannot, count there.
Okay, and then my last question really, I think, is for Ariel. This goes to the MedPAC recommendations versus what is adopted by Congress. And if we were to think about a reference-based pricing, if we were to reference off of sort of the base rate, maybe with some adjustments for wage index or whatnot, but not with all the other add-on payments, how would you think about our work in referencing off that with regards to what Congress adopts versus what MedPAC recommends? So say if MedPAC recommends an upward adjustment that Congress doesn't adopt, how should we think about that when referencing to that Medicare rate?
So it's something you might want to consider, keep in mind, because of how the legislative process works in Congress. They are, for various reasons, they're not going to may not want to adopt MedPAC's recommendations. For example, it might increase federal spending, and there are reasons they don't want to do that. Or it might reduced payment rates for certain sectors like post-acute care, where there is a lot of, there strong support for those sectors and lots of pushback against MedPAC's recommendations. So, but in terms of, you're thinking, if you want to think about what is, an adequate rate, at least under Medicare, you might want to consider MedPAC's payment adequacy assessment and their recommendations as you determine what the appropriate benchmark should be, and if you want to make any adjustments to the Medicare base rate. But I'd say it's ultimately a policy decision that you would need to make.
Thank you for that. That's all I have. And again, thank you so much for the presentation and coming today.
Sure.
I'll jump in. Is that okay, Owen?
Please.
I don't have a lot of questions. I was curious about the site neutral payments that Medicare makes. I believe it was for OPPS hospitals on one of your slides. And I was wondering which services they're doing that for, or if you could just expand a little bit on that discussion.
Sure, no problem. So this is combination policy. Is some of the policy has been mandated by Congress. Some of it CMS has done based on existing statutory authority, and it's gone in some cases beyond what Congress mandated. So there, an important distinction here to draw is that there are two kinds of off-campus outpatient departments. You've got ones that have been around, you've got the total set of outpatient off-campus departments, and then you've got newer ones that were created in 2015. And the reason why this matters is in 2015, Congress passed a law that said for these newer off-campus outpatient departments, site neutral policy will apply to all non-emergency services provided in these off-campus OPDs. So clinic visits, diagnostic tests, procedures, whatever they do, the rate has to be reduced to the approximate level of the fee schedule rate. Then CMS came in later and through other statutory authority, extended site neutral policy to all off-campus OPDs, whether they're new or older, and for certain services. And those are clinic visits. And that policy was established, I think about 5 years ago. And then this past year, CMS extended that policy to drug administration codes. So if a patient receives chemotherapy in an OPD, off-campus OPD, they get paid for the cost of administering the drug. The payment for the drug itself is usually separate. And that payment is now going to be equal to the fee schedule, physician fee schedule payment. And that went into effect on January 1st of this year. So it's a bit of a complicated answer, but Medicare is often quite complicated.
Super complicated. So Medicare can tell through the payment bill, through the billing codes, which are these new and old OPDs.
So it's a bit more complicated than that. So they can tell through the billing system, through a claim, whether the service was provided in an on-campus outpatient department or an off-campus outpatient department. There's a different process for determining whether this is an off-campus department that began billing after November 1st, 2015. I think that information is collected by the MACs, the Medicare Administrative Contractors, and I'm not exactly sure how CMS takes that information, how CMS takes that information into account when it pays the claim, but it's probably done at the MAC level.
Okay, so you would have to, someone making a reference to Medicare would have to adopt this adjustment in order to have the same treatment of these off-campus payment sites. It's in the later adjustments, not the base.
Correct.
Okay.
It's not in the base. You could
Super
look at,
helpful.
I mean, you could look at claims, you could look at Medicare claims and get a really good sense of whether or not, a hospital has off-campus OPDs that are subject to the site neutral policy. Because you could compare their payments to payments for, payments that what they would have been paid under the OPPS without any reduction.
Okay, that's
One,
really
can
helpful.
I
Yeah,
jump in and
please.
just add to my understanding in the commercial market is that kind of those modifiers that appear on kind of Medicare claims and are required for Medicare claims are not necessarily consistently used on the commercial side today because it's not required and payments are not necessarily adjusted based on that. And so both like in thinking about the base rates, you may need to also kind of then require kind of that these billing that information be conveyed on the claims form on the commercial side to allow you to implement a similar billing structure here. It's not necessarily obvious in the commercial claims data.
Okay, great, thank you. And then this is just a hypothetical, but would it be possible with public information to make a chart of the hospitals in the state of Vermont and discuss all the adjustments made for each hospital? So that we could see exactly where they're all being adjusted upwards and downwards. I'm just asking if the information is public enough to figure all that out.
I think for the facility level adjustments, generally, yes, at least on like the IPPS and OPPS side. A lot of that it's in the kind of cost report data. The one caveat I can think of was on that cost side, as I mentioned, I could not find any sources where you can tell if it's like method 1 or method 2 for the physician billing at the critical access hospitals.
Okay.
That I couldn't uncover publicly.
Okay, great, thank you. Those are my questions.
I'll go ahead and jump in next. Thank you both for being here. Very helpful presentation. I just had a couple questions. I wanted to ask the first one about the relatively efficient hospitals that MedPAC has identified that you spoke about on one of the earlier slides. Could you help us think about how we should interpret the minus 1% Medicare margin among relatively efficient hospitals?
Yes, let me give you some background on that. MedPAC identifies a set of hospitals that are relatively lower cost and provide relatively higher quality consistently for a number of years. And I don't recall the exact details of that method, but I can refer you later on to reports where they've discussed it. And the idea there is, there's some judgment involved, but the idea there is, can we identify a set of relatively efficient hospitals, remembering that we want to ideally ensure that a relatively efficient set of providers can have adequate payments to provide services to beneficiaries. Let me go back to that. Let me go down to that slide. There we go. And so I think why you're seeing a much higher fee-for-service Medicare margin for those hospitals is because MedPAC has selected those that have relatively lower costs versus those that have higher costs, which are, when they calculate the overall fee-for-service Medicare margin, which is minus 12.6%, you're including a lot of high-cost hospitals in there as well. So the thing is really a function of their ability to constrain their costs.
So that's very helpful. The relatively efficient hospitals are near break even with Medicare on average, meaning some in that group are profitable with their Medicare population.
Presumably.
And yeah, and so it's the cost discipline that becomes the key among the efficient hospitals.
Correct. Correct.
Thank you.
Mhm, mhm.
The just one more question. That was very helpful. I appreciate it. When we talk about the base rate versus the fully adjusted rate, and we're thinking about reference-based pricing, could you just, and I know later speakers are going to speak to this, so it's just kind of, I'm interested in your thoughts and also kind of teeing up later discussion. Could you help us think about how policymakers should think about the differences between the base rate with the local wage index adjustment, and that's it, versus the fully adjusted model that you also talked us through? Do you have any concise thoughts on pros and cons of either approach?
I can jump in with an initial thought, and Ariel, please follow. But really, the percentage that you choose can be, adjusted up and down and set anywhere. And so, say for whatever your median hospital is, you can kind of pick that and ultimately have them be paid the same amount of money, whether you're under one approach or the other. So it's not really about kind of how much you're paying overall, but it's how much variation you allow across the hospitals. What all of those additional adjustments are doing, generally speaking, is accounting for facility-specific characteristics that are different. It's kind of whether you want to be paying more for, a hospital that has a residency program. It's whether you want to be paying more to a hospital that has a certain rural designation. And so, you could pick 200% of Medicare and use the, full rate with everything in, and then maybe like 250 or 300% of Medicare. These are random numbers. I'm not suggesting you use any of these, but just, for illustrative purposes, or 300%, and just use the, geographic and case mix add in. And maybe that kind of comes out the same for one hospital. But again, it's just like whether you're adjusting for differences between the hospitals and think that, we should be paying more or less to account for that. And that's just a policy call, whether you want to bake that into your program.
Great. Your final sentence, I was going to say, it's sounding like it's a policy decision, that there's no real recipe here that anyone could fall back on and say, this is the correct way to do it. This is a policy approach. And I think some of our later speakers are going to talk about the ways that it's been done other places. So thank you very much. It's been really helpful. Thanks for your time. Thanks for putting this together for us.
And one thing I'll just add quickly is that a lot of these adjustments are designed to account for factors that are outside of the hospital's control.
Mm-hmm.
So there are many things that there are many costs that hospitals can manage, but if there are certain factors that they really can't control. So, for example, if they're treating a financially vulnerable population that costs more than the typical, Medicare case, or if they have higher costs because they have a residency program, and there's lots of evidence that when you have a residency program, there are higher costs associated with that, related to additional tests and additional time to treat a patient, or use of new technologies. So there are certain factors that that's kind of the rationale for why there are a lot of these adjustments. There are adjustments that are not well targeted, and are not kind of in that category of accounting for factors beyond the hospital's control. But I just want to put that framework around why many of these adjustments were created, even though over time they may no longer be well targeted, or may become distorted or create distortions of the market.
I appreciate that context about how they were created. I think that's important to understand. It's a great reminder. I think it's also, what I heard you say was that over time there's at least the potential for some drift in the behaviors the organizations adopt in response. So for example, we see some organizations that have a rural designation on one aspect and an urban designation on another in the same facility. So there's some drift, there can be some drift away from the intent that you started with, if I heard you correctly.
Yeah, and particularly, and Christine can talk more about this as well, particularly with the wage reclassifications. There's a lot of behavior going on, which providers, hospitals are, taking advantage of the system to, leveraging the system to increase their Medicare payments.
Okay. Again, thank you very much. Those are all my questions.
Thank you so much. Appreciate your time. I've learned a lot. I have two quick questions. One, actually, with this slide up, can you just talk a bit about the productivity adjustment that's done annually? What that's intended to do, and a little bit about that?
Right. So the productivity adjustment, in more detail, it's based on the 10-year moving average of changes in economy-wide private non-farm total factor productivity as measured by Bureau of Labor Statistics. So in other words, it's meant to measure total changes in productivity across the entire economy, not for each specific sector or for the health sector specifically. And Congress adopted this as part of the Affordable Care Act when they created the marketplaces and subsidies for people to purchase coverage through the marketplaces. And you could think of this as a budgetary mechanism, to reduce Medicare spending in the long term. And then they were using those savings for other purposes to increase coverage for, the under 65 population. There was no, I don't think there was a rationale for this in the legislation or the conference report, but we can look into that. So essentially, think of this as a way to reduce the growth of Medicare spending over time. And this is this provision does not expire. This is indefinite, and it applies to all of the fee-for-service payment systems, except certain ones like CAHs that are paid differently.
Okay, thank you. That's helpful.
Sure.
And my second question, really, it's a bit piggybacking on my colleague Tom's question around the hospital efficiency and how MedPAC assesses that efficiency. And I know you offered, thank you kindly, to follow up a little bit on the methodology. I guess one of the things I'm just curious about is, in that methodology, are there themes emerging around the hospitals that tend to fall into the category of efficient? Are there characteristics, size? Are there characteristics of rurality versus urban? Are there characteristics, that certain types of hospitals are able to, leverage economies of scale on the one hand, and also all of these payment adjustments are working in the way that we expect them to. So I'm just wondering if there's any follow-up to that. It would be really helpful for us as we're thinking about a state that has many small hospitals serving rural areas. So anything on that, I guess I would just say, if you have anything, know anything, can share anything, it'd be super helpful to understand MedPAC's way of assessing efficiency. So thank you.
Yeah, I don't know offhand, but I can send you the information I can send you the reports where they discussed this adjustment. And I think they have looked at the characteristics, and that information will hopefully be there. So I'll follow up about that.
Wonderful. Thank you so much, and for both of you for this wonderful presentation.
Sure. And I would just add on the kind of commentary on payment adjustments working as intended. Maybe I think probably one of the main ones from MedPAC and that Ariel mentioned is around kind of moving away from kind of this DSH and uncompensated care framework to kind of a different model. And I believe it might be in our resources, if not page, if not, we can send a follow-up kind of a MedPAC chapter that's kind of discussing like why this kind of change is necessary. And just like one particular thing to think about right now is like that, and this MedPAC's kind of criticism has preceded this, but the current model was adopted, switched to in 2014 with the kind of coverage expansion under the Affordable Care Act. And right, so it's rewarding as a kind of like uncompensated care, and it's but the metrics of like who qualifies for DSH payments, including uncompensated care payments, is tied to your service of low-income Medicare and Medicaid patients, and we thought we'd have a lot more Medicaid patients. Now suddenly we may have many fewer Medicaid patients, which means fewer hospitals may qualify for that payment suddenly. And so this is a situation where kind of we have these designations, policy has changed significantly. And so now maybe the designations have not kept up with what the policy landscape looks like today. But so that's just one example, again, of where things are changing and not necessarily adjustments may not match where we think resources should be going.
Great. That's a helpful example. Thank you.
Great. Thank you both very much for entertaining our questions and for providing this overview for us. It's really generous of you to help provide a lot of important foundation. So thank you. And just keeping things on schedule, it looks like we have Professor Whaley and Professor Murray next. And I want to thank Professor Whaley and Murray for being here. I've read a lot of your work. And Professor Whaley has been with us a number of times here at the Care Board and has had a lot of influence on certainly my thinking. And I know a lot of other board members. You've been really generous with your time. So I want to thank you both. And I'll turn it to Elena if she has any other introductory comments before we turn it to our guests.
No, I think we can dive right in. So Roz, I see that you've been able to share your slides. So I think we're all set. Thank you.
Great. Thank you so much. And you can hear me okay?
Yes.
Great. Thank you for having me and thank you for the introduction. It's just going to be me today. My name is Roz Murray. I'm an assistant professor at Brown University in the School of Public Health. And today I'm going to share some of our research on reference-based pricing and talk through some considerations for the state of Vermont, particularly regarding benchmarking to Medicare payment rates. So before I get started, I just wanted to step back and provide a little bit of context, why we're talking about reference-based pricing. There's been a large and growing body of economics research that shows that high and rising hospital prices paid by commercial insurers are one of the primary drivers of rising healthcare spending in the U.S. So if we look at changes in the price of goods and services in the economy over the last couple of decades, some things have obviously become more affordable, things like TVs and computer software, but hospital services have become extremely expensive over this time period. So this is just one way to visually demonstrate how hospital prices have changed over time. But there's a lot of research evidence coming out to suggest that these high prices are not driven by higher quality of care or higher underlying costs, but they're largely associated or linked with hospital consolidation and market power. And these price and spending increases have also been linked to rising premiums, higher out-of-pocket spending, so deductibles, even wage stagnation. So here you can see that premium growth has really outpaced growth in inflation and worker earnings over the same time period. So these hospital price increases are squeezing worker budgets really in two ways. Reduced take-home pay as premium growth outpaces wages, and they also consume a larger share of household spending through higher out-of-pocket spending. And again, just want to reemphasize that the literature really suggests that these high prices are not necessarily driven by higher quality of care or rising costs, but largely associated with provider market power. Now, taking a look at commercial prices for hospitals relative to the prices that Medicare pays, we see that there's a lot of variation across the U.S. So on average, hospitals in Arkansas are paid maybe 1.6 or 1.7 times what Medicare pays, while hospitals in Florida are paid 3.5 times what Medicare pays. You can see here that Vermont ranks 14th in the nation with prices that are about 283% of Medicare. So almost 3 times what Medicare pays. And remember, we were just having a really, I think, important discussion about Medicare payment formulas, and that these are largely based on assessments to actually estimate the underlying costs of providing care to patients, and that there are hospitals that are efficient that can actually break even under Medicare payment rates. So commercial prices that are, 3 times higher than Medicare's really allow hospitals to generate somewhat of a large margin on their commercial patient populations. Even within the state of Vermont, there's a lot of price variation ranging from 140% of Medicare to 315% of Medicare. Generally, we can see that the critical access hospitals, which are shaded light green here, have lower prices relative to Medicare, while the state's PPS hospitals tend to have some of the higher relative prices in the state. Now, healthcare purchasers in other states across the U.S. have pursued reference-based pricing in an effort to try to reduce price variation and improve healthcare affordability. And my colleagues and I have evaluated some of these prior efforts. So I'm going to spend a little time sharing some of our findings from this work and also share some savings estimates, preliminary work that we were able to do for the state of Vermont. The first well-known example of reference-based pricing was a program pursued in 2011 by the California Public Employees Retirement System, or CalPERS. And at the time, CalPERS found that it was paying wildly different prices for a standard set of services across the state with no link to quality. So CalPERS pursued reference-based pricing for a small subset of shoppable procedures that were commonly provided, things like knee replacements, colonoscopies, setting a cap on what the state plan would pay for these services received by their beneficiaries or members. Under the program, CalPERS observed about a 20% reduction in the prices that it was paying for these common services, and there was evidence of quality improvements through steering patients to lower cost, higher quality care settings. Now, another example of reference-based pricing is a policy that was pursued in 2017, passed in 2019 by the state of Oregon for its state employee health plan. Now, instead of focusing on a set of common shoppable services, the policy applies to all hospital services, and it sets benchmarks based on Medicare payments. So for in-network services received at hospitals that contract with the state, prices are capped at 200% of Medicare, and this is just the facility side, so for facility payments. And out-of-network services are capped at 185% of Medicare, so there's a slightly lower benchmark to try to encourage hospital participation within the plan insurance network. Only 24 of the state's 62 hospitals are subject to this policy. These are larger hospitals in urban settings. So the policy really exempts smaller rural critical access hospitals. Now, just want to briefly provide an example of what visually how this would work. So here is a hypothetical example of 6 hospitals, and the red dots represent, on average, their prices that they're receiving, from commercial payers or from the state relative to what Medicare pays. So a policy that were to set an upper ceiling at 200% of Medicare would mean that all of the hospitals with prices above this 200% cap have to lower their prices to the ceiling or below in order to comply. So here, hospitals 1 through 4 would have to reduce their prices to 200% of Medicare, and not, instead of 245, 220, 275, or 290%. Now, in a series of evaluations conducted by myself and some colleagues, including Chris Whaley, we found that Oregon's policy led to reductions in both inpatient and outpatient facility prices. Inpatient facility prices declined by 3%, and outpatient facility prices declined by 25% under the policy in the first couple of years. We found no evidence of cost shifting, so there was no evidence that prices for the non-state employee commercial population at these targeted hospitals increased following the implementation of the policy. We also observed some reductions in out-of-pocket spending, so the state employees paid about 9.5% less in coinsurance and deductibles in the outpatient setting. There was some increase in service use, suggesting, at least in the short term, that these state employee members are not experiencing access to care barriers. And finally, we just had a recent paper examining the impact of Oregon's policy on hospital finances, operations, and patient experience of care, and we found no significant changes in any of these measures. So the hospitals essentially were continuing to operate as they were previously. Now, when we take a look at the price reductions and estimate overall savings for the state employee health plan, we estimated that over the first 2 years, savings were about $100 million, so about $50 million per year. Out-of-pocket savings, what the state employees experienced in savings immediately really were around $2 million over this time period. And the revenue reductions that the hospitals experienced from the price reductions was represented about 1% of these hospitals' total patient care revenue. So from all of their patient populations on average. So 1% reduction in revenue. So based on Oregon's policy, my colleagues and I estimated what other state employee health plans could save across the country if they were to implement a policy similar to Oregon's. So modeling a 200% price cap across the US and specifically targeted to state employee health plans, we estimated that the savings would be around $7 billion annually, as little as $3 million in Rhode Island, all the way up to almost $1 billion in California. And annual savings we also estimated specifically for the Vermont public employees and educators, and this was estimated around $90 million at the 200% price cap. Now, using the same data sources and methodology, we also estimated savings for the broader commercial market within the state of Vermont. So Vermont employers, other purchasers, and their members, with a cap set at 250% of Medicare. So here we estimate that a cap at 250% of Medicare, and this is of the final payment, the commercial purchasers and employers and their members in the state would save about $278 million annually. On the right-hand side here, you can see that the savings or revenue losses from the hospital's perspective are broken out by hospital, and more than half of the savings would come from capping prices at UVM, which has some of the highest prices in this state. We also estimated savings from price caps set at 200 all the way up to 400% of Medicare. So again, this figure shows the savings by the 6 PPS hospitals in the state. And what you can observe is that a lower price cap will result in larger savings. So a 200% price cap generates estimated savings of around $425 million, whereas a cap set at 400% of Medicare savings decline to about only $10 million. Now, I think a key question that remains is, thinking about what the right benchmark is to use in a reference-based pricing policy or approach. Is Medicare the appropriate benchmark? If so, should it be the final payment, or what percentage should the cap potentially apply? So, I think it's important to take a look at Medicare payments within the state of Vermont. We're not going to provide a recommendation today, but we're going to share some research that we've conducted that can hopefully inform your decision making. So my colleagues and I conducted an analysis examining how Medicare inpatient payments in Vermont compare to other states. What we did is we used Medicare payment formulas to estimate the average payment for a standardized case. And by standardized case, I mean we're assuming that there is a DRG weight of 1, just so that the case is comparable across the various states that we're comparing and the hospitals that we're comparing. We account for the base payment rate and all of the potential add-ons and policy adjustments. So again, you might remember from the previous presentation, there are add-ons for teaching hospitals, rural or isolated hospitals, and hospitals serving a high share of low-income patients. Here, when we're ranking states based on their final IPPS payments for a standardized case, Vermont ranks around 9th in final payments, which is above the national average. It's a little bit hard to see here just because of how small the figure is. But if you were to look at the blue bar in Vermont relative to the states kind of surrounding Vermont in this ranking, Vermont's base rate looks kind of low relative to these other states. So it's really these add-on payments that are kind of driving Vermont up in terms of the ranking. Now, if we look at how Vermont PPS hospitals compare to their neighbors, so hospitals in Maine and New Hampshire, we see that generally payments are pretty similar. You can see the different components of the final payments a little bit better here. So the blue bars again represent the average base rates, and these largely just vary based on the hospital wage index, so specifically geographic factors. And then there are the add-on payments for hospital-specific characteristics. And we can see here that one of the larger add-on payments in Vermont is the hospital-specific payment, which is specific for sole community hospitals within the state of Vermont. I'll just note that this data is from 2023, and I believe since then, UVM actually has received the sole community hospital designation status, so they similarly would be able to receive that payment increase due to the sole community hospital status designation. Now, in addition to our analysis, there was a report conducted by the advisory board that finds that Vermont hospitals are some of the lowest paid in the nation. And there are some very key differences really in terms of methodology and data sources that I will highlight in a couple slides. But I think the main difference really is the fact that their analysis relies on average payments, which means that the underlying cases themselves are not directly comparable. And I'll again talk about that in a little more detail. So the advisory board's analysis used claims data and conducted a retrospective analysis of what Vermont hospitals have been paid on average for a specific diagnosis or DRG. Now, what this does is it embeds the case mix differences that may make Vermont payments appear to be lower than other states. So, for example, Vermont has some of the highest inter-hospital transfer rates in the nation, cases where patients are transferred to another hospital. Often these transfers occur out of state. And what this does is that it makes the average look lower because the Medicare payment is reduced, becomes a per diem payment, as Christine, I think, shared earlier, when the case is transferred out of the hospital. Another key difference is that the claims payments don't include all of the add-ons and adjustments that hospitals receive. For example, I believe uncompensated care payments and value-based care payments are not actually captured in the claims data. So the analysis doesn't include the entirety of what hospitals are actually paid. Now, in contrast, our analysis examines what Medicare would have paid for that same particular, patient case. So what we do is we use hospital data, Medicare payment formulas to estimate for a particular commercial patient case, what would Medicare have paid if this patient were a Medicare beneficiary? This approach allows us to manually apply all case-specific adjustments. So, for example, if the commercial case is transferred, then the Medicare payment would be adjusted down to reflect that the case was transferred, and that's what the benchmark would be kind of referencing. As you saw earlier, we're also able to account for these hospital-specific add-ons as well. Another important point to emphasize is that Medicare payments are not based on last year's patients or last year's spending. Payments are really determined by current year formulas and policy adjustments. So it's critical to think about these estimates as reflecting how Medicare would pay today for the same patient in the same clinical circumstances. Now, I think it's also useful to talk about what other states have done. So I shared the case of the Oregon State Employee Health Plans reference-based pricing program. How do they reference Medicare payment rates? So again, the Oregon State Employee Plan sets a cap at 200% of Medicare. And the Medicare payment that they are referencing is the Medicare final payment rate. So it includes all policy adjustments and add-ons. The policy specifies that the maximum reimbursement shall be determined by the carrier applying the applicable percentage of the Medicare rate or the Medicare rate of similar services or supplies as of the date of service of the claim. So the benchmarks are based on what Medicare would have paid for that case on that particular date. It may also be useful to walk through an example of how this applies. In a specific example of an Oregon school district teacher, again, this is kind of made up for just to kind of demonstrate how this might work. This teacher, Alex, receives a hip replacement at an Oregon hospital, is admitted on May 5th and discharged a day later. The insurer has negotiated to pay this hospital about $40,000 for the hip replacement. But because Alex is a state employee, the price is subject to the 200% price cap. So essentially, the payment benchmarks to what 200% of what Medicare would have paid had Alex been a Medicare beneficiary. So looking at this specific case, a hip replacement at an Oregon hospital, admitted May 5th and discharged the next day, Medicare would have paid $17,670 for this hip replacement. And so Alex's insurer cannot pay more than 2 times that amount, which is $35,340. Because the negotiated rate was greater than this amount, the payment drops by almost $5,000. Now, I think it's worth looking at an example within the state of Vermont, and we can also compare the Oregon approach to using an average payment for this particular DRG to even referencing the Medicare base rate. So I'm going to walk through another example. In this case, a public employee, Jordan, receives a hip replacement at a Vermont hospital, admitted on 10/9 and discharged 2 days later. Again, the insurer has negotiated to pay $40,000. If we were to look at what Medicare would have paid if Jordan was a Medicare beneficiary, this hospital would have received $18,842. So if the cap were set similar to Oregon at 200% of the Medicare final payment, the payment would not be able to exceed $37,684, reducing the paid amount by about $2,000. Now, if the benchmark was based on the average payment for DRG 470 at UVM, the cap would be set at a significantly lower payment rate, so $18,000. This is even less than what Medicare would have paid for this particular patient case and lead to a very large reduction in the payment made to UVM for this case. Again, the average payment is going to appear lower here because of case mix differences. Transfers out of the hospital are going to make the payment on average look lower. And also it doesn't include some of those add-ons that I mentioned earlier. Now, an alternative approach is that the benchmark could be set based on the base payment rate, so excluding all of the add-ons and policy adjustments that are made to this particular hospital. If you look at the price ceiling, if it was set at 200% of the Medicare base rate, the insurer would not be able to pay more than $25,724, which would result in a larger reduction in the price, but still a higher price ceiling than would be set under the average Medicare payment amount. So again, I think it's important to emphasize, what Medicare would have paid for a particular patient case is the standard approach. It's what has been used in other reference-based pricing initiatives, specifically in Oregon. It also results in much higher payments conditional on the same price ceiling. Again, the state could consider referencing the base rate to reduce variation across PPS hospitals. So in this particular example, we see a cap set at 200% of the final payment creates a lot more variation in the price ceiling, the hospital-specific price ceilings that each of these hospitals experience, versus if you were to set a higher percentage of Medicare based on the Medicare base rate, there's a lot less variation in the price ceiling across these various hospitals. As mentioned previously, this is not meant to serve as a recommendation, but just to aid the board in evaluating options for cap levels and potential benchmarking. Now, I just want to also note that my presentation and our analyses have primarily focused on PPS hospitals. We haven't really spent much time on critical access hospitals, which I know Vermont has a lot of. And that's largely just because they're paid differently. And so benchmarking might be a bit more challenging, as maybe we, kind of discussed earlier. I'll note how other states have chosen to deal with critical access hospitals, both in Oregon and Washington. They've chosen to exempt critical access hospitals from their reference-based pricing policies, recognizing that these hospitals may have less flexibility to absorb losses, revenue losses under price ceilings. I think regardless of the approach, though, it's really important that these hospitals are considered carefully in the policy design. Thank you so much for your time. Please don't hesitate to reach out with any questions, but also obviously we have some time also to address questions now as well. Thank you so much.
Thank you so much, Dr. Murray. That was really, really helpful. I appreciate the context that you provided, the overview of our system. I'll turn it to Ms. Barabee. Do you have any questions before I go to the board?
I don't. Feel free to dive right in.
Great. Okay. I'll turn to Member Merman. We can go the same order. Merman, Teachout, Walsh, Holmes.
Great.
Sure. Thank you. Thanks so much for the presentation. It was super helpful, very clear. I really appreciate it. I just have a few questions on the slide where you had sort of the light green, dark green bars, the critical access hospitals and the PPS hospitals as percent of Medicare. Can you comment on a little bit on the difference between or why you think the critical access hospitals are so much lower as a percent of Medicare on all but one compared to the PPS hospitals?
Yeah, I mean, so this is research that my colleague Chris Whaley conducted. Can you see this screen?
Yeah. Yeah.
Okay. Yeah, I mean, I think in general, this is not true of all critical access hospitals, and I'm not specifically well versed in the dynamics in Vermont in particular. But a lot of these PPS hospitals tend to be part of larger health systems that have more significant market power than some of the critical access hospitals, and so have greater leverage to command higher prices than some critical access hospitals. I'm not saying that this is necessarily the case in Vermont, but in general, that is part of why we see much higher rates within these PPS hospitals. Critical access hospitals, they're in rural communities. They serve a really important patient base. And there certainly are cases where that critical access hospital might have the monopoly power to be able to request higher prices. But I think there's generally just a little less leverage among critical access hospitals than these PPS hospitals. I hope that answered your question sufficiently, but I'd be happy to follow up with additional information if that's useful.
Thanks. Yeah, I might just ask you a question follow-up. I can email it to you. I appreciate it. The other question I had for you was on your simulated rate. What are the components of that simulated rate again, just so I understand
Yep.
what that
So
represents?
yeah, maybe this slide is a little bit easier. So essentially, CMS posts data on their final rulemaking every year. These payment rates are just the IPPS payment rates. So we're not looking at OPPS or other CMS Medicare payments. So this is just IPPS. Basically, what we do is we take we apply the formulas that Ariel and Christine discussed earlier. So we start with the federal operating base rate and capital rate for year 2023, and then we make adjustments to both of those rates based on the local area hospital wage index, and that's how we essentially how we get to a base rate. And then what we'll do is we look at the hospital IME shares, as well as whether it's a sole community hospital, and within the payment data, it has information on what those payment amounts would be, and so we adjust those based on the case. In this particular example, the case is just a DRG weight of 1, so then we can kind of sum up the total payment amount for a DRG case of 1 for each of these particular hospitals, looking at the base rate and all of the additional add-on components. So we're just using the formulas that are within the final rule.
When you go to the slide where you have the 3 different columns of options and reference-based pricing approaches, and I think it was, that one there. Okay, all right, so the simulated Medicare amount is what you discussed there, and then the simulated Medicare amount base rate is, what's that?
That would just be referencing the blue bars.
Okay, and then
so,
the average Medicare amount is purely the average Medicare amount.
Exactly, yep, right.
Okay, I appreciate that, thank you.
Mm-hmm. And just to note, because I was looking at a DRG case of 470, I can't remember exactly what the case weight is, but maybe it's closer to 2. I would be multiplying the blue bar by whatever that case weight would be, 2, or multiplying the full standardized payment by that case weight as well, and that's how we get to the particular simulated amount for this particular DRG, if that makes sense.
It does.
Okay, great.
Thank you. Thanks again for the presentation.
Thank you.
Hi, I'm Sarah. I do have one question about the methodology difference you discussed between what you did and what the advisory group did. And one of the other questions I had there is, because it's comparing Medicare payments, and tell me if I'm wrong, but does it also exclude patient copays? So if copays are very high for patients, then those are being excluded, or is that not true?
That is a good question. I am not entirely sure. I believe that the copayment would be included. It would be for inpatient care. I believe it's a deductible. So that's going to vary based on where the patient is within their hitting their deductible. So I believe that I will have to revisit that question, but I think that's a really important question. But it would vary.
It's pretty specific. And then my second question is more about implementing reference-based pricing in the states that you showed us. Oregon, for example, they phased it in really by the state employee coverage population, and then only applying to PPS hospitals. And you, in your findings, you say that didn't impact the hospitals, but Vermont's looking at something a little bit more broad. And I was just wondering if you had recommendations about better ways to phase in reference-based pricing. Do you recommend doing only a narrow-based population or only certain types of hospitals first, or are there other approaches you think would be more balanced?
Yeah, I think that's a very important question. I guess I will just emphasize that a price cap, a price ceiling, is really just targeting the highest prices within the price distribution. So there are, if we look at this particular example, there are likely, some patients that are, receiving a hip or knee replacement from University of Vermont Medical Center, and the negotiated rate is below 200% of Medicare. And so those prices would not be impacted by the reference-based pricing policy. So if you were to implement a higher price ceiling, there are fewer cases that will, be capped essentially. But you would just want to be cautious or careful that prices below the price ceiling do not increase to that price level. So if you were to set a cap at 500% of Medicare, you're just targeting the highest prices within the distribution. It's a smaller set of cases. That's not likely going to be a lot of cases. But you just would want to be sure to prohibit prices below the cap from increasing towards the price cap.
Great.
So trade-offs to think about.
Thank you. Those are all my questions. I appreciate your presentation.
Great. Happy to.
I'll jump in next. Thank you, Professor Murray. Great presentation, very informative. I too would I just have one question. It's more interpretation and kind of forward looking a little bit for us. But in the Oregon and CalPERS data, the prices were brought down by the intervention. Patient cost share declined. And there were no decreases in access or quality. And the concern, if I understood things correctly, was that if we push down on prices, then access would suffer or quality would decrease. And that wasn't shown in the data. Is that correct?
That is correct. Yep, exactly.
So in Vermont, we've seen declining quality as our prices have been going up, and access has been a concern for quite some time. So we need to improve those. And is there anything in any of the data that you've seen that would suggest they could not improve under price constraints?
That quality could not improve under price constraints. Yeah, I mean, I will. So, within my summary of this third analysis that I shared, we were examining the impact on hospital finances, operations, and patient experience of care. We actually observed some very minor improvements in patient experience of care at these particular hospitals. So that might suggest that the hospitals are then trying to reinvest in ways to attract more higher paying patients. Even if you were to implement a price ceiling, the commercial population would still be a higher paying patient base than the Medicare or Medicaid patient populations. So, we observed some minor improvements in patient experience of care. But this is an area that we would like to continue studying just to understand, especially over the longer term, monitoring how quality of care is impacted.
Great. So if I heard you correctly, that there's a concern that under price restrictions, access could decline, quality could decline. But if anything, so far, your data are showing that they can improve.
Right. Yeah. So we saw increases in, increases in use of outpatient services, may or may not be an indication of, access being improved or positive improvements in access to care. We haven't examined, I think there's more research that we can do in this particular space, but at least it suggests that these patients aren't being turned away from those hospitals. So they're still receiving care from these hospitals.
Great. Thank you for walking us through that. It's a surprising result, unexpected given prior assumptions, and it's just really helpful to hear you explain that to us.
Yeah, of course.
Thanks.
Happy to. Thank you, Member Walt.
Thank you. It's actually great to go after Tom, Member Walsh here, because I actually just want to follow up with a slight tweak on that same question. And this slide is perfect. So we see from your studies there that there was no evidence of cost shifting to the non-public or non-state employees. But I'm actually wondering if what we're seeing here is there any evidence of what we might call, supplier induced demand, right? The price goes down. And so what we're seeing is no significant changes in hospital finances, and we're seeing outpatient care increasing. Is that suggestive of hospitals, seeing lower prices and then increasing utilization? And I guess my question would be, is the utilization that you're seeing, that outpatient care, is it increased access, reduced wait times, such that people who really need to get in for necessary care are now able to get in? Or is there any way to unpack whether this is necessary or unnecessary care that's increasing in order to, kind of hold revenue constant?
Yeah, I think that's a really important question and not something that we were able to dig into in particular within this paper, but certainly could be a response. Hospitals are experiencing a revenue loss, and so they respond by increasing, service use and volumes. And I think Mr. Murray later will talk about Maryland's experience, but I believe there was a case where they took away their volume adjustment, and there was a big response in terms of volume, a big increase in volume when they took that away. So certainly what could be going on here, and a response and something that requires additional study, but also might be something that you all want to think about as well, if you're looking at price caps.
Great. Thank you. And thank you for this great presentation and all your great research on this topic. It's really helpful.
Yes, thank you so much.
Great, thank you. I have no additional questions, although immense gratitude for your work. I mean, you're widely read across the country, and we really value what you add to the group think on these issues. We have our next presentation is scheduled for 11:30. I see Ms. Vangeli is here now, so we can just get started unless people want to break. Okay, why don't we take 5 minutes, and so start back at 11:25. I have to step out for another meeting, and so I will turn it to Member Holmes to chair the Care Board's hearing until I'm able to return. And we'll be back at 11:25. Thank you.
right, just checking that folks are here. I see Dave, I see Sarah. Tom, excellent. All right. I don't have my full screen, but does the Baylett team, do you all want to post your slides? Just want to make sure that we have those up.
Yes, I think Sarah will be screen sharing.
Sarah's the navigator? Okay.
Yeah.
All right,
You're all seeing
wonderful.
that? Okay, great.
Sarah, it's good to hear your voice and see you and all of that. And Ms. Vangelli, I haven't met you, but thank you so much for coming. And Ms. Kinsler, it's great to see you again. And I'm going to kick it off to you all. Thank you.
Great, thank you so much. So I'm going to get started. My name is Alyssa Vangelli. I'm a managing director at Baylett Health, and much of my work focuses on partnering with states on projects to advance healthcare affordability in the commercial market. So I'm very excited to be with you all today talking about reference-based pricing. As some quick background, Baylett Health, on the next slide, is a health policy consulting firm. We're located in Needham, Massachusetts. But as you can see, we have staff located across the country. We also have quite a broad geographic reach, having worked in 46 states and Washington, D.C. Our clients primarily include federal, state, and local government agencies, healthcare purchasers, health systems, foundations, and national organizations involved in health policy. We do have some history working with the Green Mountain Care Board on affordability initiatives. With support from the Commonwealth Fund, Baylett Health launched a commercial market affordability strategies technical assistance program in 2023. The initial scope of that program included more broadly commercial market affordability strategies. And for the most recent 2025-2026 program cycle, we've narrowed the scope to focus on hospital pricing strategies in particular. GMCB has participated in the TA program since its inception. The first project focused on rate review affordability standards, where the Georgetown Center on Health Insurance Reforms worked with the GMCB to establish an analytic framework to more effectively consider consumer affordability in the rate review process for the individual and small group market. The current TA project focuses on policy design and support for reference-based pricing. We've been working with the GMCB on thinking through how initial implementation could work through the phased-in approach that Elena described earlier in the meeting, and also lessons that can be learned and applied from other states, which will be the bulk of our presentation today. So I'll note that primarily through this TA program, we have partnered with states on supporting development and implementation of reference-based pricing, including support with policy design, stakeholder engagement, messaging and communications, monitoring and compliance, and mitigating potential risks and unintended consequences. So our agenda for today has three main components. I will first provide an overview of existing hospital reference-based pricing policies, highlighting that while other states can provide valuable lessons for Vermont, there are also unique aspects to Act 68 and the state's current regulatory environment that will most certainly impact policy design. And then my colleague, Sarah Kinsler, will do a deeper dive to review some of the core key policy design decisions that GMCB will need to consider in developing its reference-based pricing program, and how lessons from other states can help inform that thinking. And then we'll do a wrap up at the end. Okay, so as you are all certainly well familiar with at this point, reference-based pricing, which is also, I just want to note, people tend to refer to it as payment limits, payment caps, or price caps, which are all essentially used interchangeably. Limits payments to a specified level. These limits are usually pegged to a percentage of Medicare rates for the same service, but they could also use another pricing benchmark. I'll note that reference-based pricing typically also applies to inpatient, outpatient hospital services, but they could be applied to a narrower set of services or more comprehensively, including, for example, hospital employed professional services based on state policy goals. And as we've heard, reference-based pricing directly addresses a primary driver of healthcare spending and spending growth, which makes it one of the most effective tools for controlling excessively high hospital prices. The strategy's impact primarily depends on both the cap level and, excuse me, how broadly the cap is applied. Okay, so there are several ways that states can apply reference-based pricing, each of which entails varied scopes of which markets are impacted, and with different state authorities and regulatory levers. A narrower application leverages the state's purchasing authority to implement hospital price caps or reference-based pricing for the state employee health plan in particular, such as in Oregon, as you heard about previously. Though the state employee health plans typically represent a small segment of the commercial market, they're usually the largest employer-based plan in a state and include a significant number of covered lives. Second, states can impose payment limits on carriers in the fully insured market via state insurance regulation. And finally, the broadest approach, where Vermont is to use provider price regulation, which allows states to implement reference-based pricing across both the fully and self-insured markets by limiting the commercial payments that hospitals can accept. So thinking about ways that reference-based pricing can be customized regardless of the regulatory approach used, states have several options for thinking about design. So one example is that a policy, reference-based pricing policy, could be combined with a policy to cap the growth in commercial payments. And Vermont's current hospital budget review authority can be leveraged to do this, as it currently limits commercial reimbursement rate increases. In addition, states could consider establishing minimum payment rates for specific services or provider types, such as primary care or behavioral health, to support state policy priorities, such as improving access to essential services or addressing provider shortages. And we know that this is something that you all will be considering, as Act 68 provides that the GMCB may implement reference-based pricing for services delivered outside a hospital by setting the minimum payment amounts paid for services that could include, for example, primary care. Other areas for customization include phasing in certain services like hospital employed professional services, given the operational complexity of including professional services. And we understand that that the state is currently considering such a phased-in approach, as well as providing exceptions or accommodations for certain hospitals. For example, hospitals with the highest prices could have a glide path to allow additional time to come into compliance, or other accommodations that could be informed by examining hospital financial metrics to ensure hospital financial stability, recognizing that some hospitals are financially robust while others are not. And as Sarah will discuss further, Act 68 does provide a fair amount of discretion for the GMCB to customize various components of reference-based pricing. So turning now to the existing models that have been implemented sort of pre-2025, but in one case through 2025 and through current. You heard already from Dr. Murray a lot about Oregon. Oregon, I'll just, as a reminder, is has the most extensive experience to date implementing a hospital price cap policy. They've done so since 2019 for the state's public employee plans, beginning in 2019 for public educators, and then early 2020 for other public employees. And just as a reminder, under the policy, the state's contracted insurers and third-party administrators limit payments to inpatient and outpatient services to no more than 200% of the Medicare rate for in-network and no more than 185% of Medicare rate for out-of-network. Oregon's policy remains in effect today and provides the strongest evidence of success based on evaluations conducted thus far, again, as you heard about from Dr. Murray. Under Washington's public option program, which began in 2021, all public option plans are required to cap aggregate, not service-specific hospital reimbursement at 160% of Medicare rates. And then a program that was in effect from 2016 to 2022 is reference-based pricing through Montana State Employee Health Plan. So rather than doing straight price caps, the state negotiated and contracted with each hospital to reimburse at a range of Medicare rates for inpatient, outpatient services. The policy ended in 2023 when the state selected a different third-party administrator for the state employee health plan, but one evaluation that was conducted showed that it generated an estimated savings of $47.8 million for the state over 3 years. So we see some success for that program as well. We saw a flurry of hospital price cap legislation in 2025, and several proposals made it over the finish line, which is exciting. So I'll review these. New Mexico passed legislation to authorize hospital price caps in the state employee health plan. The legislation itself has a broad directive to implement a price cap to help offset enhanced financial support for state employee coverage, which is also included in that bill. The New Mexico Healthcare Authority subsequently issued program guidance stating that effective July of last year, the state employee health plan would no longer reimburse urban in-network hospitals more than 200% of Medicare, and out-of-network hospitals more than 175% of what Medicare would pay. Washington also passed legislation last year limiting how much their public employees and school employees' health plans would pay for hospital inpatient, outpatient services. Those limits are set at 200% of Medicare for inpatient and 185% of Medicare for outpatient. The policy will become effective January 2027. And I'll note that that legislation also established minimum payment levels for primary care and behavioral health services delivered in the community to at least 150% of the Medicare rate. Indiana passed legislation containing 2 hospital price cap policies, the first requiring nonprofit hospitals in the state's largest systems to bring their aggregate average inpatient and outpatient prices under the statewide average by June 2029. If a nonprofit hospital fails to meet this requirement, the hospital forfeits its nonprofit status until it lowers its prices below the average. And the second policy requires the state's largest hospitals to offer direct-to-employer contracting arrangements with price caps set at or below 260% of Medicare. Vermont, as we know, uses the GMCB's provider rate setting authority to implement price cap requirement across the fully and self-insured commercial market. And I do want to note that while no other state to date has used provider rate setting authority to implement price caps, there is a long history of rate setting in the United States, which Bob Murray will cover further in his presentation today. So as we think about how Vermont can learn from other states that have implemented or will soon be implementing price caps, it's important to consider both lessons learned from other states' experience and some key differences in other state policies and landscapes that may be instructive for Vermont. And Sarah will elaborate on all of these, but I will describe a few briefly. So some areas where Vermont can learn from other state experience includes establishing reference-based pricing cap levels, including considerations of using the fully loaded versus base rates and the modeling strategies to estimate savings, as Dr. Murray discussed. Accommodations for some hospitals based on things like facility type and designation, financial metrics, or other characteristics. Mechanisms to ensure effective compliance and enforcement of the policy, and ways in which potential risks can be identified, and ways in which the state can monitor for and mitigate against unintended consequences, such as monitoring revenue-seeking behavior, for example, ensuring that prices aren't increasing for non-capped services. There are also some key differences in Vermont's statutory mandate compared to other states, and so the GMCB will have to keep that in mind when designing the program. I think as previous speakers have discussed, one major difference is the market subject to the cap. So we've noted that Vermont's authority is the only state directive to cap all commercial market hospital prices, both fully and self-insured, at the service level. Given that Vermont is planning a broader implementation than most states, design decisions will need to consider this differential impact of a wider policy. So for example, as Vermont's program will capture hospital revenue from the entire commercial market, the policy has the potential to generate significantly higher savings than price cap policies applied to narrow market segments. And at the same time, the broad scope could have a heightened impact on hospital finances, as a considerably higher percentage of hospital revenue will be impacted. So the GMCB will need to consider this impact throughout the program design. Other differences include hospitals subject to the cap. As has been discussed, other states have wholly exempted critical access hospitals, for example, but Vermont's critical access hospitals are already regulated under hospital budget review, and so a more nuanced approach, potentially around alternative benchmarks or specific accommodations may be more appropriate. And thus far, states have applied price caps to inpatient and outpatient hospital services only. However, we know that Act 68 specifies that all hospital services will be subject to price caps. And we understand that the GMCB intends to start with facility-based services and phase in these other services over time. So with that, I will turn it over to Sarah.
Thanks so much, Alyssa. Hi, all. It is delightful to be at a Green Mountain Care Board meeting today and speaking to you all again. I'm Sarah Kinsler. I'm a senior consultant at Baylor Health. My work there focuses on partnering with states on projects to advance affordability, similar to Alyssa, including providing technical assistance to Vermont and other states through the Commonwealth Fund program. But in my prior life, I held a variety of roles at the Green Mountain Care Board, including Director of Health Systems Policy. So this feels like a nice place to come back to. So it's lovely to be here today. So I'm going to dive into a little bit more depth on key design decisions and talk through with you all considerations for Vermont as you produce a policy design or a more comprehensive and in-depth policy design for reference-based pricing. So we'll be talking through the reference-based pricing cap level and reference values, potential accommodations for some hospitals, compliance, enforcement, and preventing gaming, and we'll also touch on hospital global budgets briefly at the end. So first, we're going to talk about the cap level and reference benchmarks, and I feel like prior speakers set us up fantastically for this conversation. So as we've already heard today, both the cap level, percentage of Medicare, and which Medicare rate we are referencing, whether it's simulated Medicare, Medicare base rates, or an average Medicare rate, can have a significant impact on the actual dollar amounts that are allowable under reference-based pricing. As we've heard, existing reference-based pricing efforts have used largely of final Medicare payments, which include a variety of facility-specific adjustments. But GMCB's prior work on this has largely used base price and wage index. And there are pluses and minuses to each of these approaches, again, as we've heard today, so I'll be brief in this section. Final Medicare prices do reflect Medicare's various payment methodologies, adjustments, supplemental payments for things like teaching status, care for publicly insured patients or uncompensated care, rural location, small size. This can be seen as a benefit in that it means that Medicare prices, and if this is used under reference-based pricing, allowable commercial prices are going to reflect the cost of these activities and facility characteristics. I think it's a policy decision when we think about whether that's something that you think commercial ratepayers should support in the same way that Medicare supports these activities, but that definitely can be seen as a positive. However, that also means that some hospitals are going to receive much higher Medicare payments than others for the same services, and a higher Medicare denominator, if we're using final Medicare prices, means that, for a hypothetical possible A, commercial prices look lower as a % of Medicare than at hospital B, even if hospital A receives much higher commercial reimbursements in terms of their actual dollar value. Final Medicare prices also are not appropriate for critical access hospitals, as we heard from earlier presenters, which is problematic in Vermont. Then on the right-hand side, when we think about using Medicare base or Medicare base plus wage index, that's going to give us a more apples to apples comparison of commercial prices. So we can actually use the percentage of Medicare to think about how the dollar amounts relate to each other. So if hospital A's commercial reimbursements are a higher dollar amount than hospital B, that'll show up in the % of Medicare base because the denominator is relatively consistent, much more consistent than if we're looking at final Medicare prices. It also can potentially be used for critical access hospitals because it doesn't reflect cost settlement, and it eliminates some of the analysis of hospital-specific Medicare payment components each year. That said, it doesn't reflect things like graduate medical education and DISH payments, which some might see as a disadvantage. In terms of key considerations for Vermont, we think it's really important to select a benchmark that can be used for critical access hospitals. Vermont already regulates critical access hospital budgets through the hospital budget review process. And I think, in many ways, it would be a step back to retract from that in application of reference-based pricing. So we would recommend in that case against fully loaded kind of final Medicare prices. If GMCB takes this path, it's important to remember that final Medicare prices are going to be higher than base prices. So as I think earlier presenters showed really nicely with numbers, the cap amount just needs to be set with that in mind. So other RVP and price cap states have set their caps around 200% of final Medicare, but that's going to look really different than 200% of Medicare base prices. GMCB could also consider alternative benchmarks for services less commonly paid by Medicare, such as pediatrics and maternity. This is lightly referenced in Act 68 as a possibility. I think there are different perspectives among the researchers that we've spoken to in terms of how well Medicare prices reflect the cost of administering these services, given the Medicare population and just the scale at which they are delivered in the Medicare population. So we certainly would include that as an option. Other states have often talked about using a percent of Medicaid for those services. And then finally, and again, as Alyssa referenced, GMCB should keep in mind that Vermont's reference-based pricing policy is capturing a much larger share of the market and of hospital total revenue than other state efforts have. And so it will be really important to set that cap level thoughtfully so that, as was referenced in previous board questions, we make sure that there's still that hospitals don't feel the financial impact in a way that negatively impacts quality and access and can instead improve quality and access. So we're going to move on to talking about accommodations for some hospitals. As we've heard earlier in the day, existing reference-based pricing models have exempted some hospitals, particularly critical access hospitals. But because we don't think that makes a whole lot of sense in Vermont, we want to make sure that we're thinking about accommodations for hospitals. I'll also note that exempting hospitals raises an equity issue for patients who might continue to pay very high prices at some hospitals if they are not capped, and much lower prices at hospitals that are capped. So rather than offering wholesale exemptions, we're going to talk about accommodations, and in particular focusing those accommodations on hospitals where something, whether it be the size, rurality, financial health, or some other factor, means that the hospital might struggle to comply without concerning impacts on quality and access. And really, this means that they have the ability to financially adapt quickly enough. Of course, accommodations will need to be thoughtfully designed. So the state obviously wants to prevent negative impacts to Vermonters in terms of quality and access, but it will also need to make sure that accommodations don't just support inefficient operations or kind of allow hospitals to continue as they have, because that undermines the intent of Act 68 and would not achieve the policy aims. So broadening our scope to national, when we look at the literature, we see a lot of evidence for widening financial inequality among hospitals. So the existence of have and have not hospitals and health systems. The haves tend to be wealthy. They tend to earn quite a bit from investments, so non-operating income. They have very strong market power and high commercial prices. They tend to be larger systems, and they're more likely to be located in high-income communities. The have-nots tend to have fewer assets and hence much less income from investments, so they need to make their money from their core business of providing healthcare. They have less market power, hence typically lower commercial prices, and they're more likely to be part of small systems or independent. They're also more likely to be located in low-income communities. So when we think about the ability of hospitals to financially bear the impact of price constraints, we need to think about the variation in current hospital financial situations. When we look at data analyzed by GMCB staff, and this is from the kind of pre-hospital budget review staff presentation that was done in August last summer, we see that there's also wide variation in the financial health of Vermont hospitals. So I picked a couple of core metrics here, and not the full set that were reviewed by staff, but days cash on hand, a really critical indicator of hospitals or health systems' ability to weather financial challenges, ranges from 33, which is quite concerning, especially for an independent facility, to 199, which is really robust. So similarly, we see a lot of variation in profitability metrics and solvency and debt capacity metrics. And the variation in finances, along with variation in current commercial prices, means that some hospitals are going to struggle more than others to comply with a price cap. So what do accommodations look like? And this also was really nicely teed up by an earlier board question. How can we phase this in? Accommodations can take a couple of different forms. So one would be a glide path that gradually lowers hospitals' commercial prices to give them more time to comply with the eventual reference-based pricing cap level. So that could mean a decrease of 25 percentage points a year or 50 percentage points a year until hospitals are in compliance. And those, again, are hypothetical values, not meant to be a recommendation, but just a gradual decreasing down to the cap level. It could mean additional percentage points on top of the reference-based pricing cap based on hospital or community characteristics. So if you've got a cap of 250% of Medicare, perhaps that cap would be 255% or 260% or 275% for a critical access hospital, if that were a basis on which you wanted to offer hospitals some accommodations. Or it could be a higher cap for a hospital with high public payer mix. Accommodations could also look like a higher allowable price growth cap for facilities where the current prices are low. So as you're bringing high-priced hospitals down, you're allowing low-priced hospitals to increase a little bit more quickly to reduce that variation and come closer to kind of equity across the system. And it could also look like higher caps for particular services. So if there are services where access is threatened or where the state wants to create a strong incentive to increase access or investment, I'm thinking just based on recent news, maternity services in Vermont, you could consider setting a service-specific cap at a higher level to really incentivize hospitals to keep those services. So those are kind of generally how we can think about accommodations. I want to specifically highlight accommodations for financial precarity. That's going to be really important to have a strong framework for because the scope of reference-based pricing in Vermont is so much broader than in other states, looking across the full commercial market. So in the event that you do see hospitals whose financial health could be a threat to quality or access, GMCB will really need to be able to spot the signs of this and act quickly to issue whatever accommodations you include in your policy design. Luckily, you've got a great team of analysts who are really knowledgeable about the financial health of your hospitals and already collect and analyze a ton of data in a really comprehensive manner. So all I'll say here is that I think focusing at the health system level for affiliated hospitals is really important, especially with regard to days cash on hand and other measures of liquidity, just thinking about the full organization. So now we'll move on to compliance, enforcement, and preventing gaming and unintended consequences. So once reference-based pricing is implemented, the board is going to need to make sure that all hospitals and where applicable payers are complying. The experience of Oregon suggests that this is best done at the claim level. Oregon has historically done compliance checks in aggregate at the level of the hospital payer contract, but looking at totals masks a lot of variation in payment levels relative to Medicare, excuse me. So some claims are over the cap. They're being balanced by some other claims for services where payment levels are under the cap. And due to lower savings, Oregon has seen lower savings than they were expecting. And so they've moved to claim level compliance. And this is what we would suggest Vermont look at as well. In terms of enforcement, there will need to be a really structured framework to dictate what happens when it comes to noncompliance. And GMCB will also need to have ways of identifying strategic hospital behavior meant to circumvent the goals of the policy. So revenue-seeking behavior could take quite a few forms. We've included some examples here, like redirecting care to non-capped settings within a hospital health system. So non-hospital settings that aren't capped, out-of-state facilities, price increases for non-capped services, increasing volume of high margin services or decreasing volume of low margin services or dropping that service line entirely. And this is where the service specific higher caps could come in if that's something that Vermont wants. Work to increase coding intensity or increasing prices for just some codes or levels of complexity within codes to target price increases within the allowable charge increase. So all these behaviors would be strategies that would maximize revenue in an environment where prices and price increases for services are constrained. So to help ensure compliance and minimize potential for gaming, we suggest that the board consider a three-sided compliance framework. So obviously, hospital budget review and provider rate setting are the foundation here on the bottom, but we would suggest requiring submission of negotiated prices in standard formats through those processes. However, we think it would be also valuable to require payer compliance through rate review, and that could be in the form of review of negotiated prices and inclusion of compliance as a consideration for rate approval, but it's also an opportunity to collect payer data that can corroborate what you're seeing from hospitals and give you another view into strategic behaviors. And finally, VCURES-based analyses will be an important tool to confirm compliance and for monitoring. So there are opportunities on all three of these sides for ongoing data and analyses to track compliance, monitor quality and access, and identify and eliminate gaming behaviors. But in the near term, especially, thinking back to the phase 1, phase 2 approach that Elena presented earlier this morning, there are two policies that we think that GMCB can think about through hospital budget review that are really low-hanging fruit in terms of ensuring that reference-based pricing fulfills its intent, especially in this first phase. So first, ensuring that hospitals' net patient revenue caps reflect the newly required prices. So, if prices decrease, that should be taken into account in terms of the hospital's allowed total revenue, so that hospitals don't quite have the same option of increasing service volume to limit reduction in total revenue, despite those price changes. And second, the board could require that the limits on commercial price increases that it sets through the hospital budget process be applied to all levels of all codes rather than allowing compliance in aggregate. And that will prevent hospitals from concentrating price increases in profitable services or in different levels of specific codes where they're currently below the cap level. Last but not least, in terms of design decisions, we would be remiss if we didn't mention the transition to hospital global budgets. So Act 68 directs GMCB to implement hospital global budgets starting in FY28, which is soon, with the payment methodology reflecting the capped prices. So even though price is the focus right now, the board really can't take its eye off of total cost of care if it wants hospitals in the state to succeed under global budgets. To do this, we recommend, again, ensuring that NPR caps reflect reference-based price limits, which will ensure that hospitals are kind of moving toward operating within those revenue constraints. And secondly, we recommend that Vermont continue its measurement of total healthcare costs and total cost of care at the statewide level and at the health service area level. And I am going to hand it back to Alyssa to wrap us up, and then we'll have time for questions.
Thanks, Sarah. So just as a very quick wrap up, to remind you all that states across the political spectrum are increasingly turning to price caps to improve healthcare affordability for their residents. This is in large part driven by the fact that states across the nation are experiencing persistent premium increases, largely driven by high hospital prices. And so, as we've discussed today, there is strong evidence of the success of reference-based pricing policies implemented to date. Vermont certainly has a lot to learn from states that have experience with implementation, and at the same time, Vermont's unique statutory authority, scope of the program, and distinctive regulatory experience thus far will all influence the policy design and implementation. So we are happy to take questions now.
Wonderful. Thank you so very much. Great presentation, insightful. Elena, do you have questions first before I turn it over to other board members?
No, guys, please dive in.
Okay, great.
I could jump in first again. Nice to see you, Sarah and Alyssa. Thank you so much for the presentation. Again, we've been very fortunate today to have such clear, well-prepared, thoughtful presentations. It's just fantastic. I guess I really just have one question that's kind of a little bit on the side of this, but you mentioned potentially considering specific adjustments to hospitals based upon payer mix. And I was wondering if you could help us, if you've had some thoughts about how to think about payer mix. Sometimes we think about net patient revenue, looking at payer mix based upon the net patient revenue those payers contribute to a hospital's overall revenue. Sometimes we think about gross revenue to kind of get an idea of the services delivered. And sometimes hospitals will report individual patients. And I was just wondering if you had some first thoughts, maybe not as well prepared, on how, if we were to adjust by payer mix, what is the right measurement of payer mix to consider for that adjustment?
Thanks, Dave. Personally, I like net patient revenue when we're thinking about payer mix because charges can be so different than the prices that are actually negotiated and paid. And I think net patient revenue is a little more relevant when we're thinking about hospital financial status. But really, when we say payer mix here, that could be, that's a little bit of a stand-in for patient population. So I think you could consider, with a little asterisk here, based on previous discussions, you could consider DSH status as an indicator. You could use some proxy for payer mix, or I think as long as it's consistent, it's not necessarily specific to which one you choose. It's the idea being that it's important to support hospitals that are caring for people with public insurance or people who are self-pay.
Thank you. That's all I have. Thanks.
Okay, I think I'm next. And I'll jump in. My question, I'm really thinking about how to set a reference-based price for critical access hospitals, and you did mention that briefly. So I think perhaps you were suggesting, but clarify if you weren't, that we could select, I'm just going to say, a benchmark maybe adjusted by the wage rate and use it across all hospitals, and then make an adjustment in our reference percentage to make up for the fact that it's perhaps a critical access hospital, rather than key off some payment that's specific to critical access hospitals.
That makes more sense to me. I think as we think about accommodations, I think, it's a state policy decision whether you want to offer critical access hospitals specifically, or hospitals with a certain type of designation or of a certain size, with some kind of additional room in the price cap to allow for slightly higher payments there. I do think that the idea of using base rates so that you're not taking into account the cost settlement makes a whole lot more sense, and again, is going to give you something that's a lot closer to apples to apples.
Great, thank you. That was my only question. That's what I'm really thinking about right now.
Right, I'll jump in next. Nice to see you both. Thanks for coming. Thanks for the presentation. Very clear, very helpful. I had several questions, but I'll think just the one that I'd like you thinking about here, like your help thinking about today. When we think about hospital readiness for this, some have advocated, some of the material that you sent advocated for considering days cash on hand as a measure. And I'm wondering if you could help us. How should we think about how should we guard against the risk that larger facilities have basically more accountants, and the numbers can be days cash on hand can vary substantially from week to week, time of year, and what report is being submitted. And so it seems to me if we were to put too much on that measure, that would potentially penalize smaller places with fewer staff to be able to make those just-in-time adjustments to the days cash on hand figure. Does that make, did I explain that okay?
I think so. Yeah.
Okay. So are there, so what are your thoughts about using that as a measure or guarding against how it could be gamed? And what other measures, what might we consider looking at?
So I would say what I like about days cash on hand, even though it is point in time and it, no single measure is going to be a perfect measure of hospital financial health. What I like about days cash on hand is that it can be very revealing of who's got just a ton of reserves that they can fall back on in times when there's a drop in revenue, for example, or a regulatory change perhaps, that can allow them to adapt and kind of give them a little bit of cushion, and who doesn't have a lot of cushion. So I think even if we're not talking about like the specifics of, up 10 or down 10 days, thinking about who's got a ton of reserves that can help cushion them versus who has very, very few reserves that can help cushion them is important. That said, your team does, Matt and his team do a ton of work in analyzing hospital financials. You already do really comprehensive analysis. So in a state that didn't have those skills or capacity, maybe I would say, you could think about a targeted measure set, but your team does have that skill and that capacity and is already doing that work. So I would say the comprehensive analyses that you all are doing are very important. What I would caution against, and this isn't quite the question you asked, Tom, so you can steer me back if you need to after, but I guess I would caution against too much of an emphasis on profitability year to year. It's, obviously important that you're not in the red all the time, but ups and downs are in profitability are going to be expected. And so having some years in the red doesn't concern me as long as hospitals have the cushion to support them through those times.
Thank you. What I hear from you there, it might be useful to look at these measures over time leading up to implementation and then monitor them going forward.
Absolutely, yeah. I think looking at multiple years of data rather than looking at just one snapshot is so important. And I would absolutely recommend that. And again, your team does a great job of that already. So the board is very lucky in its financial analyst expertise.
Yeah, one of the things I think that yes, and being able to look at the share of margin that's attributable to commercial payers and watching what happens, modeling what happens if we compress that 300%, 250, 200. Thanks again for helping me think about that, and thanks for being here today.
Yeah, thank you, Tom. If I can add one more comment to that, I would just say, if we're modeling the contribution of commercial revenue to margin, that makes the assumption that all hospital operations are going to stay the same. And I think part of what reference-based pricing should hopefully encourage, and definitely part of what global budgets will encourage, is more efficient operations, as you spoke to earlier in some of the Q&A and back and forth. And so I think I don't know that we want to make the assumption that no operations will change. I think hospital operations will have to evolve. And hospitals will need to be thinking about ways to find efficiencies as this process moves forward if they're going to be successful under reference-based pricing and eventually global budgets.
Thank you so much, Sarah.
Thanks.
I just have one question for you. And I'm just wondering if you can speak a little bit to some of the complexities of applying reference-based pricing to professional services and the consequences of not doing so.
So I think in terms of applying, Alyssa, were you about to jump in?
You can start and I can jump in if you want to.
So in terms of the complexities of applying reference-based pricing to professional services, that's not something that we've seen done in other states so far. So that will be an area where Vermont is kind of building on past state work, but also charting a little bit of a new path. I think we heard a little bit about the physician fee schedule earlier. I'm certainly not an expert on the physician fee schedule, so I would kind of refer to the first presentation of the day in terms of the technical challenges of that, I guess. As we think about the consequences of not including professional services and some of the, I guess, less technical challenges, I think the complexity and the relationships between physicians and hospitals. So whether they're employed providers, an affiliated physician group, not affiliated at all, is going to be an important factor. And I think it'll be critical to think about how reference-based pricing is implemented for professional services, and making sure that that's not done in a way that like inadvertently causes some real market changes or encourages different ways of affiliating or bringing on staff as kind of a strategic behavior or revenue-seeking behavior. So I think that that's one thing to remember. I do think that as you think about broadening this to professional services over time, keeping an eye on whether hospitals are pushing services into professional settings and keeping an eye on price increases in professional settings to the extent that they're not already capped is going to be really important, because that could be a key, gaming behavior to circumvent the intent of the caps.
Okay, great. Thank you. I appreciate that. And I appreciate all of, the answers to all these questions and the presentation. My understanding is you all are going to be sticking around so far, the folks that presented to us all morning. We're going to break for lunch at this point. We are literally exactly on time, so this is wonderful. We're going to take a slight recess here until 1 o'clock. We're going to come back at 1 o'clock, and we will have Mr. Murray's presentation at 1 o'clock. So thank you all for the morning. This is very educational, important work that we're trying to do here, and we couldn't do it without the insights that we're gleaning from you all. So we're going to recess until 1 o'clock. Thank you all. Just doing a check to make sure our board members are here. Tom, Dave, are you on? Sarah? Give another minute or two. Mr. Murray, it looks like you're on. I saw your slides come up.
Yes, I just wanted to test it out, so I just unmuted myself and I'll give it a shot again here.
Wonderful, thank you.
You can see that, okay?
Now I can, yes.
Okay, all right. It looks like it's
Fantastic.
advancing. All right, I think I'm set.
Perfect, wonderful. Sarah, you're on. Is that right? So many, trying to find everybody's faces here. Dave?
I am here.
Perfect. Okay. Well, hopefully everybody had a wonderful lunch break, and we're ready for our afternoon session. I'm happy to welcome Mr. Robert Murray to our board meeting today. We're going to turn our attention to hospital global budgets, a little bit of a shift, but along the lines of payment reform. And Mr. Robert Murray has been a well-known, expert in the area of global budgets, done a lot of research in this area, implemented global budgets in his time in Maryland. So we're very lucky to have him. And I want to thank you again for coming and sharing your wisdom with us. So I will turn it over to you.
Absolutely. Thank you very much, Commissioner. So just very briefly go through the outline of my presentation. And then also, please do feel free to interrupt me during the presentation. If you have a burning question, I'll obviously keep time for at the end to answer questions as well. But I just wanted to talk a little bit about my background, sort of an entry point for government regulation, a rationale for regulatory intervention being trying to address market failure. So I'll talk a little bit about that. Provide some background, as you had mentioned. I've done a lot of research about the history of rate regulation in the United States. So I'll talk about the evidence, how it's worked in the past, what's happened since regulation sort of subsided, rate regulation for hospitals, that is, in the mid-90s. Discuss the current situation, impacts on affordability. These are all things that you're well aware of, but it's worthwhile emphasizing. And then turn to Vermont, some pros and cons of the approaches that you've taken in the past. Talk just very briefly about reference-based pricing. Obviously, Dr. Murray and others have talked about that. I think it's a great starting point. And then focus on global budgets, including what we used in Maryland, which was, a flexible global budget model. So I'll emphasize that. And then finish with some discussion about regulatory failure and regulatory capture. And these are two of the big potential pitfalls and Achilles heels of regulation, then talk about some next steps. This is my background. I guess the primary experience that I would highlight is when I was at the Maryland Health Services Cost Review Commission as executive director for over 15 years. So that's where I really kind of understood a lot more about health policy and payment regulation and implementation. I've done a few other things. My claim to fame, I think, right now is that I'm related to Dr. Roz Murray. She's one of the two doctors in our family. So just very briefly, rate setting in the United States, I think it's worthwhile to go back and look at the history of it. This approach really was, and this is a quote from Jerry Anderson, who wrote several articles about rate setting in the 80s and 90s, that it was at the center of the health policy paradigm back then. There was many 30 states that had some form of rate setting or rate review or mandatory rate setting. And I'll review the literature, but the literature conclusively shows that the mandatory rate setting states that had legislation that strongly enforced the prices that were set by a regulatory body in the state, were very effective in the period 1975 to 1985. And there's a lot of literature that I've tried to cite along those lines, that conclusion. Maryland, New York, New Jersey, Massachusetts all had success in controlling prices and also meeting other goals. And I'll touch on some of the other policy goals that rate setting can address. Interestingly, this doesn't get a lot of attention, but Rhode Island had a successful mandatory multi-payer. It was essentially all-payer global budget model that worked extremely well in the 70s and 80s. Also, Rochester and the Finger Lakes area in New York implemented a all-payer global budget model from 1980 to 87 that was similarly very successful in controlling price growth and also achieving other goals, such as stabilizing the financial situation of many of the hospitals in that area. And I'll talk about that. The literature shows also conclusively that more voluntary rate review, less targeted regulatory systems were less effective and in many cases ineffective in controlling spending and price growth over time. So I'll make that differentiation in this presentation between rate review programs and mandatory rate setting, which have targeted price setting or price caps, that those mandatory systems are far more successful. So evidence from the literature going back to the mid 70s and mid 80s about rate setting, the clear ability to control hospital price and spending growth. And you think about it, it's kind of a tautology. If a state has the authority, the legal authority, and can enforce prices that they set and the rate of growth of prices, it stands to reason that you can control the spending growth of a state, hospital spending growth over time. Now there's some variations on that, and I'll talk about controlling price and then controlling volume, because both are equally important. And if you clamp down too hard on prices, volumes tend to grow. Hospitals will make it up on volume, and I'll illustrate how that takes place. The literature also found that all payer systems that create uniform incentives across Medicare, Medicaid, commercial, self-pay were more effective in controlling costs and also funding uncompensated care, support small hospitals, creating more financial stability. So all payer systems have the ability to be more successful. Systems in the past also improved equity across all dimensions: pricing equity, equity between have and have not hospitals, in rural underserved areas in particular. So that was something that was a very positive outcome from rate regulation. The thing about some of the approaches today, reference-based pricing, even global budgets, is they do less to actually address pricing equity across services and across payers, although that can be accomplished. But initially, you should keep that in mind. Pricing equity is very important for patients, obviously, but that will take more time to address. It also, as I said, improved financial stability and predictability in the system, and that was the case in all of the jurisdictions that I mentioned, maybe with the exception of New York State, although Rochester and the Finger Lakes had improved financial performance under their rate models. So most studies also indicate that rate setting did not erode quality, and I think that now with pay-for-performance incentive approaches that Medicare has adopted and Maryland adopted, you can actually improve hospital quality. And so I would recommend that the Green Mountain Care Board look at the metrics that Maryland has implemented to provide incentives for hospitals to improve their quality. There's some evidence that rate setting diffused technology or slowed the technology diffusion. That was the case in things like open heart surgery programs. There are fewer number in rate setting states than other states, but overall, not that much of an impact on the overall delivery system. There was one circumstance where rate setting, let me go back, there were several circumstances where rate setting were found to be incompatible with managed care, although Maryland did manage to create a system that was compatible with managed care growth, and that delivery system changed. So it's not given that rate setting will conflict with those types of market-based delivery system changes. Now, the demise of rate setting really occurred after the mid 80s. You saw the rise of managed care, which is more effective or an effective impact in controlling hospital costs and spending over time. Although, I would argue that that was kind of a one-time impact on the growth rate over time. The real seeds that were sowed to undermine rate setting occurred ironically, and this is kind of backed up by those who have researched the history. The rate setting was so effective in these states that clamped down pretty significantly on hospital price and revenue growth that there was a significant pushback, political pushback in many of the states, including Maryland in that period in the 90s. That led to legislative changes that undermined the effectiveness of rate setting. And then more broadly, there was an anti-regulatory sentiment in the country in the 1980s, and that also contributed. We saw evidence of some regulatory failure and regulatory capture in some of the states, which undermined confidence in the rate setting systems that were state-based. There was the implementation of the Medicare prospective payment system in 1984. That also contributed to states jettisoning their rate setting systems because many of particularly the teaching hospitals found that the Medicare IPPS was far more generous in paying their teaching hospitals than their state-based systems. So the industry and the states decided to eliminate rate setting in part due to that. That occurred in Washington, New York, New Jersey, Massachusetts. The very successful Rochester Finger Lakes demonstration also was terminated because the big teaching hospitals in Rochester realized they could do better under Medicare. That sounds ironic now, but do better under Medicare than under their systems. Maryland largely continued, I think, because rate setting was structured a little differently, but the real reason was there were significant consequences for the system failing and being terminated. And I can go into that, but that whole point of having consequences is very important for the success of a rate setting system and also to help fend off some of these other influences like regulatory capture. Since that period in the late 1980s and early 90s, obviously we've talked about this during the presentation earlier, you've seen considerable market failure. That's really the entry point for regulation. The theory of regulation is address market failure, attempt then to do no additional harm because regulation can disrupt the delivery system. And so that's an obvious threat and something that bodies like the Green Mountain Care Board need to be very cognizant of. So avoid unnecessary interventions. That was kind of our mantra in Maryland. But of course, the key market failure is the pricing power, as Roz and others have demonstrated in their presentations. And I think that the rise of managed care in the 80s and 90s led to hospitals figuring it out and deciding to consolidate their market power, starting first in Massachusetts with the Partners merger and then spreading across the United States pretty dramatically so that hospital mergers and acquisitions, as Roz had mentioned, strongly correlated with hospital price increases over that period. And so just a snapshot, we saw prices benchmarked to Medicare were about 117% in the mid-90s, and they've increased fairly steadily ever since to being about over 250% now.